of the COVID-19 case management guidelines. These are our references, and we would like to thank all those that made the study possible. Thank you.
Thank you, Linda, for effectively using your time. The next presenter will be Brian. Brian will take us through SARS coronavirus to postpartum testing of out-of-hospital natural deaths. Brian, you will have 10 minutes. The floor is yours.
All right, good afternoon, everyone. My name is Brian Brummer. I'm from South Africa, from the Field Epi Training program there, and I'll be presenting on SARS-CoV-2 post-mortem testing of out-of-hospital natural deaths in the Mwangea metropolitan area of the Free State province in South Africa between August 2020 and August 2022. So COVID-19 is an infection caused by SARS-CoV-2 virus, which originated in China, which is we all know. It's been quite thoroughly investigated and reported worldwide. And early in the pandemic, it was sort of thought that South Africa or Africa had been largely spared death related to COVID-19 infection. However, these were explained largely by reasons such as a high rate of the BCG vaccine, a low importation risk to Africa, and maybe a more biologically plausible one was the low median age of Africa. However, this was still sort of largely unknown, and to summarize it with an adage is that an absence of evidence is not evidence of absence. So we didn't quite know what the true extent of COVID-19 related death in Africa really is. An excess death can represent the upper bound of the real or true number of COVID-19 deaths. And a systematic review places the excess deaths during COVID-19 as a factor of 3. So for every COVID-19 death that was reported, potentially 3 more actually exist. In South Africa, we also have an excess death report by the South African Medical Research Council. They utilize the Holt-Winters method to estimate the excess deaths using the preceding 5 years' death data. And they also come up with a similar number of an underreporting factor of 3. So on the graph here, you can see in blue the number of excess deaths in South Africa that were calculated by the SAMRC. And below that in red, the number of reported COVID-19 deaths. And so in between those two lines is this uncertainty. We don't know who, what, or where these people come from. And so in response to this report, the South African Department of Health, together with the NICD, and also together with Emily from Africa CDC, implemented an enhanced surveillance project in select districts in South Africa that focused on improving community death reporting instead of just in-facility reporting. Ad hocly, we can see that the presentations before us focused purely on an in-facility population, and a limitation of this was that it lacked representation of the true extent of the disease in their sample. So we implemented enhanced surveillance, and my aim now is to report on this enhanced surveillance. It wasn't a research project, it was a program. So I'll be reporting on the number and proportions of deaths reported through the enhanced surveillance in the Mwangea district, and then determine some demographic differences in the reported versus what would have otherwise been unreported COVID-19 deaths in this area. So this is the setting of where this enhanced surveillance was implemented. On the left is a map of South Africa with 9 provinces. Free State is a country on the interior of the country. It is next to Lesotho, which is an enclave. There are 2 national roads that pass through it, which is important when we think about the infection and how that was transmitting. One is vertically from Joburg to Capital, which are two capitals in the city, and laterally from Lesotho across the country. On the right, you'll see the Free State Province, and in the circle there is the metropolitan area of Mwangea, with Bloemfontein, the judicial capital of South Africa. So we identified 3 main areas to implement post-mortem testing of natural deaths in this area. The first was a community death occurs and the emergency medical services, or EMS, needs to declare the death. That was opportunity number 1, to collect a nasopharyngeal swab. Number 2 was the private funeral parlor industry is quite active in South Africa. They collect the body and handle the death notification process and burial processes. And the third one was when the medical practitioner certifies or notifies the death. So those were 3 opportunities we found, and we leveraged on all 3 of those in collecting a nasopharyngeal swab, and we conducted a PCR for SARS-CoV-2 on that swab. We then compiled repositories of all out-of-hospital natural deaths using both a public and private mortuary registers in the area. That repository was then linked to COVID-19 laboratory test data and case line lists, and the outcomes were recorded in an outbreak management system called GoData. So we're going to present the findings using counts and proportions. We'll compare the demographic characteristics with the Kruskal-Wallis test for continuous data and a chi-squared test for categorical data. So first, during the analysis period, 5,150 out-of-hospital natural deaths were recorded in the repository. Of those, 56% had a SARS-CoV-2 post-mortem test conducted, and 414 of those tests were positive, for a positivity rate of 14%. Just to note as well that private funeral parlors performed 26% of the post-mortem tests. This is a table comparing the 3 contexts of deaths that we were able to find by implementing the surveillance. So on the left, we have community deaths. This is a death where a case would have been identified as positive, so an anti-mortem test, and then was not referred to a hospital, was not severe enough to go to the hospital, and died in the community or out of a hospital. The second is a case who died in the community outside of a hospital or facility, and then was tested for COVID-19 and tested positive. And then the third was the standard in-facility anti-mortem tested death. So we find that there is a difference, or a statistically significant difference, in the median age of these 3 populations. However, we're unable to demonstrate a statistically significant difference in the gender proportion between these 3 death categories. This graph now is quite similar to the first one I presented. In blue is the excess death calculation for this area, and we can see that represents the upper bound of the true extent of COVID-19 deaths in that area. Below that, in yellow, is the in-facility deaths. This is what usually gets reported in COVID-19 surveillance. And then in between that is the red. So this represents the community deaths in the area. We implemented the program most strongly in 2021, and so in between those 2 vertical lines is where we would probably see the largest proportion of post-mortem tests or community deaths contributing to the overall reported number of COVID-19 deaths. So we can see we were somewhat able to close the gap between reported deaths and excess deaths, and somewhat being able to provide a person, time, and place to otherwise unreported COVID-19 deaths. Unfortunately, this closing of the gap was unable to be maintained. So in discussion, the utilization of morticians and burial services and other stakeholders made the implementation of post-mortem testing and enhancing surveillance easier, and this should be identified as a verbal autopsy stakeholder. Real-time reporting of cases and reported deaths and excess deaths was useful for rapid decision-making in South Africa, and this is because our CRVS system lacks the real-time surveillance data we need to make these kind of decisions. However, even with this enhanced surveillance, a gap still remains between reported COVID-19 deaths and excess deaths. The cause of deaths in South Africa is still unknown for the 2020 to 2023 period, and this data is expected to be available around 2028. And this highlights the need for improvements in the civil registration and vital statistics system in the country to monitor causes of deaths in near real time. In conclusion, the number of reported COVID-19 related deaths was enhanced by focusing on community death surveillance. Demographic differences may exist between those who were reported and those who may have been unreported. Enhanced surveillance explains some of the excess deaths. However, without cause of death information, the remaining excess deaths are difficult to explain. Improvements in the CRVS system is vital to respond appropriately and timeously to future public health threats. These are my references, and thank you very much for listening.
Thank you, Brian. The next presenter will be Charles. Charles will take us through factors associated with mortality, patients with severe COVID-19, Nairobi Metropolis, Kenya. Charles, you will have 10 minutes.
Thank you very much. My name is Charles Mulwa. I'll be taking you through factors associated with mortality among severely ill COVID-19 patients in Nairobi Metropolis. To start with, the period under this study was the period of 2020, from March 12 when we reported the first case in Kenya, all the way up to 31st of December 2020. And by then, globally we had over 82 million cases with 1.8 million deaths, and 2.7 in Africa, with a case fatality rate of 2.2, with over 96,000 cases in Kenya, and 1.7 case fatality rate. WHO defines severe COVID-19 as a patient with confirmed COVID-19 with oxygen saturation below 90% at room air and a respiratory rate above 30 breaths per minute, with all those ranges as per different ages, and then with several signs of severe respiratory distress, which may include use of accessory muscles for breathing, patients unable to complete a sentence, among other things like severe chest injury in children. What are some of the gaps that we saw then that made us to go into this study? There were a few studies that had been done in Kenya, and also there was a big problem as far as availability and accessibility of some of the supportive treatment as far as they were concerned, oxygen, intensive care units, and other supportive treatments. So we thought that availability or unavailability of such would affect the outcome of patients. Our objectives were to determine the proportions of severe COVID-19 patients, describe the socio-demographic factors of such patients, and also determine the factors affecting leading to mortality in such patients. In methods, this study took place in Nairobi Metropolis. Nairobi Metropolis comprises of counties of Nairobi, Kiambu, Machakos, and Kajiado, with a population of about 20% by 2019 census. So this was our interest because most of the cases were reported in this area, and also this is the capital city of the country and is the business hub and the point of entry for many people coming from outside the country. This was a cross-sectional study where we did a chart review of patient records stretching from March 2020 to December 2020. And data was abstracted from inpatient files using standard abstraction tool. In data analysis, we used Stata to analyze this data. We did univariate analysis. We did means and median for continuous variables, frequencies and proportion for categorical variables. In bivariate, we did bivariate outcomes, and those less than 0.2, we took them to a backward elimination logistic model. We did all the ethical approvals for this study. And the results, we abstracted 818 records, of which 39% were non-severe, with 61% being severe. Through randomization, we were able to select a sample of 300. Globally, we had a mean age of 53, with non-survivors having a mean age of 58, and survivors having a mean age of 48. Looking at the demographics and signs and symptoms, we see that the age group of 51 to 110 was the most affected, with 55.7%. Males were most affected at 66.8%, and the fever was around 33%, with difficulty in breathing being at 64%. We had a lot of results to this study, but we were able to just put the most important. So like for most of the factors, we were looking at the point of admission and duty isolation. For example, for oxygen concentration at isolation, below 90% of the patients had an oxygen concentration below 90. Hypertension at 28%, diabetes 29% of the patients, with chronic lung disease of 3%. At admission, these patients were usually categorized. Most patients had severe disease at around 67%. And acute respiratory distress, patients who went into acute respiratory distress were 26%. With a patient who did not receive oxygen administration during admission being over 71%. ICU admissions were very few at 3.7%. Looking at the associations, we saw that some of the associations were being over the age of 50, difficulty in breathing. Others included presence of comorbidity, hypertension, chronic lung disease, oxygen and concentration below 90, and the severe status at admission. Other factors associated with mortality among severe COVID-19 illness include acute respiratory distress, cardiac failure, lack of treatment with oxygen, and ICU admission. Independent factors that were finally associated with severe COVID-19 included hypertension, treatment with oxygen, acute respiratory distress, and disease of severity at admission. In discussion, we see that high proportion of patients were reported to have severe disease compared to earlier studies, which was at around 20 to 30%. And this can be defined by a more sensitive case definition for severity that was later given by WHO. Difficulty in breathing was important in that COVID-19 is shown to affect mostly and damage the respiratory system with little damage to other organs. We also saw that lack of oxygen administration during admission was a very crucial thing, and studies have shown that administration of oxygen during admission for severe patients usually improves outcome with reduced need of ventilation and with improved saturation of oxygen after treatment. In conclusion, we see that difficulty in breathing was an important symptom other than fever, and some of the factors that were associated with mortality included severe illness at admission, hypertension, lack of oxygen treatment, and acute respiratory distress. We recommend that clinicians should not only rely on fever for patient screening, but should have high index of suspicion in terms of patients with difficulty in breathing, especially patients advanced in age. We also recommend sensitization of clinicians for early identification of patients and treatment, and also administration of oxygen upon admission. This study, inclusive of other studies that we had done earlier, was used to inform the early guidelines for treatment of COVID-19 patients in the country. Those are my references. Thank you.
Thank you, Charles. The last presenter will be Sira. Sira, you will have 10 minutes. The floor is yours.
Ok, merci beaucoup. Je me nomme Guilavogui Sira Hélène. Je viens de la République de Guinée. Je me fais le devoir de vous présenter les résultats de l'évaluation du système de surveillance de la COVID-19 dans la région de Zérekoré en octobre 2021.
My presentation will follow these facts. Introduction: COVID-19 is a viral zoonotic disease, and it causes different variants. The diagnostic includes PCR, and the treatment vaccination is essential to avoid this pandemic. COVID-19 is a disease that must be declared immediately and treated case by case in both active and passive ways. It's important to detect cases and epidemics, manage them, identify and trace contacts, and then also evaluate the repercussions of the pandemic. The region of Nzerekore is one of the 8 regions of Guinea with 37,653 square kilometers of surface area. It has 6 hospitals, different health centers, 4 health centers. COVID-19, the first case was registered in February, and in 12 March 2020, Guinea registered its first COVID-19 case. And this helped to strengthen the surveillance system. And on 13th June 2020, the region of Nzerekore registered its first case. And 24th October 2021, the 406 cases were confirmed with 31 deaths. And the system needed to be, surveillance system needed to be improved and evaluated, and this happened 2 years afterwards. The general objective is to assess the COVID-19 surveillance system in the Nzerekore region. The specific objective was to assess the simplicity, donor quality, promptness, acceptance, and the positive predictive values. And then the current directives of CDC Atlanta were used as a part of our methodology. And then data was collected using face-to-face questionnaires. These quantitative data were used to evaluate representativity. For the data analysis, we used linear list through individual collections of data using Excel as a tool. Regarding quantitative data, the linear list was used, extracted from the DHIS, and then proportions were calculated accordingly. Methodology, we had different people interviewed from the regional health body, and to assess the simplicity, 6 indicators were concerned with objectives for each. To evaluate the data quality, indicators were considered, and good quality indicators were considered if they had a figure of 80%. Regarding timeliness, 4 indicators were considered. First of all, the cases detected within the first 24 hours. And studies were carried out within the first 24 hours and results given within 48 hours. Regarding acceptance, 3 indicators were considered. The first of all, being able to participate in the epidemiological surveillance. And those who thought that this surveillance was part of their objectives. And then the positive predictive value was assessed to you, and then the positive proportion among the tests was realized. Regarding representativity, this was analyzed using the DHIS2 database to determine the number of cases of COVID. And then the usefulness was based on the objectives of the system. If you look at the simplicity results, we notice that the indicators did not achieve their objectives. The system was very new and not known by the service providers. Regarding data quality, then 60–80% of items were completely correctly filled. So this needs that epidemiologists needed to get more information to improve their data for COVID and Ebola. Regarding timeliness, all the indicators achieved their objectives. 100% of the service providers accepted to be part of this epidemiological process, and they thought that this surveillance was part of their tasks, and 100% of the health centers had notices put up in this regard. And then the positive value was 24%. Representativity, the system was representative. Usefulness, this system was useful, and were able to detect isolated cases and manage them. Conclusion, the system was useful, timely, acceptable, and representative, able to detect the real cases. However, the system was complex with some mediocre data. With regard to our assessment, we have carried out activities to improve the surveillance system. For example, training using DHIS2, supervision of data, and data collection using certain super users. And then involvement of service providers in the investigations, getting their feedback and briefing them was very important. In addition to organizing training sessions of workers was very helpful. Recommendation: at the central level, we need to simplify the form for data collection. Thank you. These are the references. I thank you for your attention.
Thank you all the presenters for your excellent works. So this is the time for question and answer. We will have 15 minutes allotted for the Q&A session. So in order to use our time effectively, I kindly ask to address a very clear question and try to address the specific presenter so that we will try to use our time effectively. So I will give the chance by raising your hand. Okay, from this row. Yeah, please. Thank you. From this row. Any person from this? Thank you. From this row. Thank you. Anyone? Okay, the last person.
No, can you give number?
Yeah, 1. Yeah, 2 is there, and 3. First person.
Yeah, thank you very much. Great presentations. Congratulations to everyone. My question goes to my brother who presented from Kenya on the mortality in relation to COVID. I saw in your results or conclusions, you spoke about oxygen being, lack of oxygen being the cause or contributing factor. I just want to find out, in your methods, you mentioned that you rather looked at SPO, the patient's SPO. Did you actually monitor or have information about oxygen therapy from this patient? Because that is what will make you to be able to conclude on oxygen being a factor. If you can elaborate a bit on that. Thank you.
Thank you. Second.
Okay, thank you, and good afternoon, everyone. I just have 2 questions which relate to the utilization of the results of these studies. The first question will go to Linda from Zimbabwe. You recommended that the institutionalization of COVID-19 vaccinations into the routine system of vaccinations for the country. How far have the country gone in relation to the implementation of that recommendation? And then the second one will go to Brian from South Africa. We did not see, after your conclusion, what the data was used for, maybe as part of public health actions. What actions did you take after getting those results? Thank you.
Thank you. The last question.
Thank you. My question goes to presenter number 1. I think it's Cosmo. So in your study, you recommended early consultation, especially for high-risk patients. So I just want to check if that has been done, and if it has been done, what strategies were used to ensure that high-risk patients are consulting early? Thank you.
Thank you. So I will call the presenters to respond to the questions. So I think, so Linda, Brian, and Charles, would you please come to the stage so that,
Kindly to the podium.
yeah, please. So, no, yes, stand there. So I have one question in addition to the questions posed by the participants. My question is, what was your motivation to conduct the study? So we'll start from Charles, I think.
Thank you for the question. The question was about whether we monitored the flow of oxygen. As I said, maybe that is part of our limitations for this study. The best thing would have been to do a prospective cohort, but that was not possible. So we did data abstraction. So what we were looking at, we were basically looking at whether this patient was able to receive oxygen during the entire period of admission. And what the patients that we noted that were not able to receive oxygen completely, they were the patients that we were looking at. And such patients that was one of the factors that contributed to mortality. The motivation towards this study, we had done an earlier study that we tried to characterize all the initial COVID-19 deaths in Kenya. Actually, the first about 100 deaths in the country. And some of the factors that we noted was the severity of illness. And so I was motivated together with my colleagues to look at the cohort of all severe COVID-19 patients who were treated by then when we were still grappling of what means of treatment was needful or was best for these patients. Thank you.
Thank you very much for the question. So the World Health Organization issued a COVID-19 transition plan, and this was for countries to adapt for the integration of COVID-19 activities into routine activities. Zimbabwe as a country is one of the countries that is working on this adaptation. I am happy to say that the country has continued with COVID-19 vaccinations, with the current coverage for dose 1 being at 62% and for dose 2 being 49%. In addition to this, the country recently underwent a comprehensive expanded program on immunization review, which is a process that is done every 5 years. And this also allowed for the country to identify opportunities for integration of the COVID-19 vaccination into the life course, focusing particularly on high-risk populations. So where that is concerned, as a country, we are making good progress, and I would like to believe that as we utilize the findings both from studies relating to COVID and the comprehensive immunization review, we will be able to achieve that.
Just gonna pull up the notes here. So the public health action as a result of this, just to be clear, this wasn't a piece of research. This was a program that was implemented that I'm now reporting on. So the public health action was that we had improved reporting of COVID-19 deaths. We had an advisory committee in the country who would look at the number of deaths as an indicator of the severity of a wave and make decisions around that as to what lockdown level to move to and what kind of restrictions to impose. So we improved the quality of that, of the number of reported deaths. A bit further reaching than that is the characterization of community deaths and building networks and how to improve community death surveillance in South Africa and Africa at large. One of the biggest ones was going to be the inclusion of morticians and burial stakeholders in mortality surveillance, specifically in the community. This is something that was largely left out in the beginning of the pandemic in South Africa at least. However, they were quite crucial in the implementation of post-mortem testing and improving the quality of community deaths in the COVID-19 pandemic. In terms of the motivation, so the motivation was primarily a response to the excess death reports where we had this huge underreporting. So a reminder that excess deaths are a representation of the upper bound of the true extent of COVID-19 deaths in the country, and the reported deaths were a lot lower than that. And so the motivation was to try and add a who, what, and where into that gap between the excess number of deaths and those who were actually reported. Thank you.
Oui, merci beaucoup pour la question. Après que nous ayons
After we had completed our survey, we made sure to put in place public health actions, including, awareness campaign, for the Provincial Department of Health in North Kivu. We made a brief presentation regarding the findings of the study. And in a radio program in Goma, we tried to raise awareness based on the findings of this study. And those are actually public health actions that we carried out. Thank you.
Give a round of applause for our presenters. So with this, we are coming to the conclusion of this session. So I would like to sincerely thank our presenters for your informative presentation and excellent works. Keep the momentum going. I hope the results, the contributions of the study will have a big contribution to the improved public health practice in our continent. I hope we will continue working in this endeavor. So we need to continue our efforts, working in fighting against COVID-19 and other, pandemics. So this is the time to strengthen all our efforts to make a resilient health system in every countries of our continent. So I would like to thank once again all for your very kind attention and participation in this important session. But final remarks, I think we are asked to evaluate the session using the barcodes available in both sides. So this is the end of our session today. Thank you. Have a good afternoon.
Yeah, sorry to emphasize on the evaluation. A second. You need to evaluate the session because when you evaluate the session, you will get your certificate at the end of the day. The system will generate a certificate for your participation whenever you evaluate sessions. Thank you.
Hello, good afternoon. Hello, good afternoon. Do we have Hani Keita here? Chukwemeka. Do we have Antonia here? Hello? No. How about Thomas Zuba Cowell? Okay. Do we have Antonia here? The first presenter? Okay. So the way we want to do it is we want to do the first 6 presenters to come and do their part, and then we have questions and answers, and then we end with the last 6 again. So I would like to call on Thomas, since he is available. IT, can you please help us to project?
So you just do this. This.
Good afternoon, ladies and gentlemen. As I've been introduced, I'll be presenting Multi-Course Agri Investigation Report from Gbapolu County, Liberia, March 18, 2023. These are my co-authors and their affiliation. Monkeypox is an re-emerging contagious viral infection. Globally, over 86,000 laboratory confirmed cases have been reported. Of these, 112 deaths have been reported as of March 21st, 2023. Bele District Surveillance Team received a report of a suspected monkeypox case in Goleta, Gbapolu County on March 13. As part of our investigation, our objective was to confirm the existence of the case, to determine the extent of the spread and institute control measures. Bele District is one of the 5 health districts in Gbapolu County with over 20,000 inhabitants with 2 health facilities. We constructed an outbreak case definition, which says anyone who has traveled to Goleta from March 11, 2023 to April 21st, 2023 that presents the following signs and symptoms. Unexperienced rash over the body, in the palm, the mouth, that has headache, experience fever, lotion, and muscle pain. We line listed contacts and follow up. As part of our method, we collected 2 whole blood samples for PCR confirmation. Ladies and gentlemen, now our result. The case of monkeypox was a 28-year-old woman, a wife of a hunter, who PCR test confirmed positive of monkeypox. She presented the following signs and symptoms: rashes all over the body. In the mouth, she has pain, and she also had lotion that itch. This is the map of Gbapolu County that illustrates the 6th administrative district. In the map, you can see this was where the case occurred with the red dot. We also established in our investigation that the case has no travel history in the previous affected regions. She has no contact with wild animals, and she is in a monogamous state relationship. We now listed 4 contacts and follow up to 21 days. None of these contacts developed a symptom. We conducted active case search in the community and in the district. There was no new case identified. This case was isolated, managed at home. The patients recover. These are photos of the case taken during our investigation. In conclusion, this was the first case of monkeypox, confirmed monkeypox in Bele District, Bapolu County. We have a possible hypothesis that this case should have been infected through the horseman who is a hunter. So we therefore recommend that further study be done to determine the source of the outbreak. We also recommend to National Public Institute of Liberia and the Ministry of Health to conduct a further genetic studies to determine a possible source or possible origin of this infection. We acknowledge the following institution organization for their financial and technical support awarded to us during our investigation. Thank you for listening.
Thank you very much, Thomas. Now, next we have Alphonse Nkololo Shonaka. Do we have Alphonse Nkololo? Alphonse. Do we have Alphonse? Okay. How about Jacques Lomanga? Jacques Lomanga. Okay. Jacques Lomanga. So Jacques Lomanga is to present on l'investigation d'une épidémie de monkeypox dans l'aire de santé, le Foucault, zone de santé de Befal, Choupa, République démocratique du Congo, 2022. Welcome. Quick.
Oui, c'est ma présentation. Comment pour manipuler ici, je clique ici. C'est tactile.
Just click on it.
Okay.
Okay. So just do this task.
Okay.
So just when you are in introduction,
Okay.
you talk, you finish, you close.
Yes.
Like that. You can use your hand.
Okay. Yeah. Okay. Merci pour m'avoir accordé la parole. C'est Dr Jacques de la RDC. Nous avons le réel plaisir de vous présenter
Buffalo Health Center.
2019. Bon. Le Mpox, comme vous le constatez, c'est une maladie zoonotique
triggered by orthoproxy-virus. This is a disease that we found in humid tropical regions in Western Africa and Central Africa. So, this disease is endemic. And this disease is endemic in the Chuapa provinces and in the Sankuru province. So the objective of this study is to confirm the existence of that outbreak and to identify risk factors, so that we can reduce the morbidity and mortality. Regarding the methodology, we did a cross-cutting study, a descriptive cross-cutting study. We collected all the cases that were in that location, and we came up with a survey. A laboratory for confirmation, and the statistical analysis was used with Excel 2016. Regarding the findings, we surveyed. We investigated 11 suspicious cases with a lethality of 45%, and the average age of the investigated cases were 11, and the profession and the habits were also risk factors. Regarding the gender, we can see the males are more predominant, and regarding the age breaks, we have those of 15 years of age were more concerned. Now, from the epidemiological week, we had an increase of these outbreak cases. This investigation helped us to confirm the case, because out of the 11 cases that we investigated, 5 were positive, which is actually beyond the level of, an outbreak, because we are saying that we used public health actions to reduce morbidity and mortality, and we also realized that we have the factors such as profession, food habits that were risk factors. So these are patients. So we raised awareness and we strengthened the capacities of caregivers. So these are actually the pictures that we took on the field. So here we have a 7-year-old child with rashes, and we have the leaders, and we have another serious case. After 48 hours, that person died. We were informed that there was also a doctor that was dead. So the aim of this investigation is to know the extent of this disease so that we could actually intervene. Thank you for your kind attention.
Merci beaucoup, Jacques.
Thank you very much, Dr. Jacques.
Mesdames et messieurs, bonjour. Je suis Charles Aboulou. Je vais présenter les résultats
of findings in the investigation in Kalibo Koulibaly. So this is an investigation around a suspected monkeypox outbreak in San Pedro in Cote d'Ivoire in June 2022. So I wish to tell you that with a confirmed case of monkeypox that was detected in neighboring Liberia, Cote d'Ivoire being on the border with Liberia, especially at the western part of Cote d'Ivoire, from Tabou, then there was a suspicious case at Iboke, and we decided to carry out an investigation on that case. So the method that we used, we had first of all to carry out an investigation in the different consultation rooms and around the case, around the contacts of that case. And we also realized that the sex ratio was 2. The sex ratio was 1, 2 men out of 2 men and 1 woman, and we also identified, contacts. Among the 10 contacts, out of the 10 contacts, the average age was between, the average age was around 43 years of age. 3 years, with an average age of between 16 and 26 years of age. So 80% of the contacts had an epidemiological linkage with the suspicious case, and 20% of the cases of the contacts had a contact with the confirmed case in Liberia, and the contacts were isolated and were put in quarantine. And as a public health events that we put in place, we brought the samples to Abidjan, Cote d'Ivoire for further tests. We also monitored the contacts, and we also took care of the suspicious case. So we also distributed notification cases regarding the definition of the case to the different health centers in the region of San Pedro. So that is actually the communication that I wanted to share with you regarding this Khalifa case. Thank you.
Merci beaucoup, Khalifa.
Thank you, Khalifa.
We have Paulette Rose Josephat Mbaye. Investigation d'un cluster des cas suspects de variole des signes dans la maison carcérale de Mbiki dans la sous-préfecture de Mbaïki, n'est-ce pas? Ok. Préfecture de la Lobaye, République centrafricaine. Ok. Paulette Rose, PAU. PAU, n'est-ce pas? Oui, yes, correct. Vous avez 5 minutes.
No what to do?
Oui. Okay. Après, X. C'est bon?
C'est bon, merci.
Commencer.
Bonsoir à tous. Nous sommes le docteur Paulette Mbaye de la République
Dr.
centrafricaine
Paulette
et nous avons
Mbaye
l'honneur de vous
from the
présenter
Central African
notre
Republic.
poster sur
I have the
l'investigation
honor to present our communication on the investigation of a cluster of suspicious cases of Mpox in the prison of Baiki in Central African Republic. In July 2022, the WHO declared, a medical emergency of Mpox, and the CAR and other countries had registered 9 cases, and on the 20th of October 2022, a new case was confirmed in the Mbaiki Sanitary District, and we also were able to locate some suspicious cases in Mbaiki, prison, so that we can seek the transmission cases. So we carried out a cross-cutting survey in the Mbaiki Health District in the south of Kar, at 108 kilometers from Bangui, the capital city. Our survey included, people in the prison. So we have a form of notification of cases and active research. We looked at the different symptoms for the people under investigation. We were able to analyze that during using a software. What did we find? Our initial case was a male, 42 years, hunter. He went to the district hospital of Baiki with a rash, and the case was confirmed on the 20th of October 2022. And active research helped us to identify 8 cases, whose age was between 21 and 57 years of age. All had fever, cough, and most of them had cough and a rash and muscle pain. So a list of contacts was made. No death was registered, and out of the 8 suspicious cases, no one was confirmed for mpox, but all were positive, and all the 8 cases of varicella were actually taken care of. And information, we did an active research in the community to find other suspicious cases. To conclude, we can say that this was actually an outbreak of varicella in a prison during an outbreak of mpox. We need to avoid promiscuity, and we need to improve hygiene conditions in the prison of Baki to avoid transmission of that disease. We have here a few references that helped us to document our communication. And we cannot conclude without thanking AFENET, who provided us with this opportunity to present the findings of our survey. Thank you.
Merci beaucoup. Thank you very much. Antonia around. Do we have Antonia? I'm asking if for the first one. Yes. It's not there. How about Alphonse? Check that one. Do we have Alphonse here? Alphonse Nkololo Sonaka. Alphonse Nkololo Sonaka. Okay. Then I think we can go on to the question and answers. Can we call on the presenters to come and sit here, please? Les présentateurs, bienvenue ici. Hello, can we have the presenters quick? We don't have time, please. Yes, so I would suggest if we can have one question per presenter for the sake of time, that would be very helpful. Can we start? Dr. Peter. Please introduce yourself quickly and then be brief in your questions.
Good afternoon. I'm Peter Dewey, resident advisor, Liberia and the Gambia. My question is to the second presenter in French. That's Kali.
The second presenter is Jacques Lomanga.
No, Kali.
Khalifa.
Koulibaly.
Khalifa Koulibaly.
Okay, yes.
Okay.
It looked like The suspect was from Liberia for the outbreak you had, if I got you correctly. I just want to ask if there was a cross-border response. Was there contact with the Liberian government, or at least with the district where you suspected that the case came from? Thank you.
Thank you very much. Any other question, please? Yes.
Yes, excellent presentations. Thank you, everyone. Uzomo Obunna. My question is for Thomas. So, Thomas, I wanted to, I may have missed it. What informed when you were constructing your case definition, you restricted persons to people who traveled to Golita. And I don't recall seeing any suspected, how many tiers in your case definition did you have? I just wanted to be clear on that. Thank you.
Okay, thank you. Any other for the others? Yes. Right.
Yeah, thank you very much. My name is Dr. Zakaria Adam from Ghana.
Okay.
Congratulations for the presentations. My question to the presenter from DRC, you presented a mortality, I stand corrected though, a mortality of 45%. Meanwhile, monkeypox, we know generally the mortality generally around 15%. Were you able to do any analytical studies to probably come out with some hypothesis? Or could you explain why that high mortality in those cases? Thank you.
Thank you, sir. Any other for any of them? If not, they respond quickly. Okay, thank you very much. You have the floor.
Thank you. If I can recall a question you asked, what informed my definition of traveling to Goleta, right? So, in Abrike's definition, we try to see where the case is. If somebody has gone there, if somebody go there and present any of these signs, we suspect that since you travel to the epicenter and you are presenting them, we suspect it to be a case until we can do further tests. So that's why we say anyone who's traveled there and present any of these signs or symptoms. But that was the epicenter.
Is that okay? He wants to know how many tiers
your case definition had. Did you have a suspected category, confirmed? I may have missed it. Just clarify.
Your question, I'm not getting your question.
Your case definition, how many categories does it have? Did you have a suspected, probable, confirmed?
Yeah, so we were looking at suspected. Once we travel to Goleta and presenting any of these signs, we suspect you of monkeypox or mpox. So we have suspected.
Is that okay? All right, thank you. Who next?
Oui, merci beaucoup pour la préoccupation et l'attention soutenue par rapport à...
For the concern raised regarding my presentation, and our colleague from Ghana asked a question regarding the lethality or the mortality discovered by our study, and was any analytical study carried out? No. Up to now, we have introductory data, and our country is still trying to study this disease. we carried out this study to find out the scope, the magnitude of this disease, and how we could envisage an analytical study, because a descriptive study must be complemented by an analytical study. Regarding the cross-sectional study that we did, we're able to come up with hypotheses which will be verified by a complementary analytical study. So that will help us to advance our studies and get more results. And when I ended my presentation, I said that one of our medical chiefs of staff died due to this disease, and this was viral on social media. And we're trying to determine which factors caused this disease. Thank you. Thank you very much for your question. Regarding the cross-boundary cooperation, we have cross-boundary cooperation between Côte d'Ivoire and Liberia. In the district of Tabu, there are exchanges with our Liberian neighbors. In fact, it is the same people who cross over from Liberia in Tabu, and they move freely between the two border areas. The confirmed case in Liberia is a person who had lived in the Tabu area. His family lived in this area, and when he returned to Liberia, the monkeypox was confirmed in this individual. And then for the one who was in Iboge, his brother was therefore identified as a suspect case, and we carried out an investigation regarding this case. So I think the cross-border cooperation exists between Côte d'Ivoire and our Liberian friends. I thank you.
Thank you very much. I think that's the end for this first part of the presenters. I must congratulate you for the good job, and thank you very much. I only encourage you to continue your surveillance system and then implementing the public health intervention strategies. Thank you very much. So we now move on to the second phase of presentation. I only hope we have the other presenters here. The next one is
Yeah, good afternoon, everyone. Yeah, my name is Ibn Hyacinth from Nigeria. I'll be making a presentation titled Descriptive Epidemiology of Mpox in Imo State, Outbreak Investigation and Response 2022, Southeastern Nigeria. We all know that Mpox is a zoonotic disease caused as a result of Mpox virus. And it has the similar symptoms to like smallpox and chickenpox, and it can be transmitted by direct touch with an infected person. Also, the beddings are also involved, the clothing sharing, and it has up to 7 to 14 days of incubation period. Sometimes it can actually happen 5 to 21 days. The first case in Imo State was actually recorded in 2018. with deaths. Then in 2022, on 6th January, we actually recorded the first outbreak. Then the objective of the study include the following: to describe the outbreak in terms of person, time, and place, strengthen surveillance for the outbreak response, identify common clinical presentation among the confirmed cases. This is the method. We have over 6 million population in the states. The 27 local government area was also involved, and about 1,113 LGA. Then we collected demographic and clinical data and generated a line list. That is, we collected swab and blood sample for laboratory confirmation using PCR. The charts and graph were used to present descriptive measures. We calculated rates and proportion. Then on the results, from January to November 2022, 133 suspected cases were identified, investigated, and tested. About 37 laboratory confirmed cases and 1 death were also reported. CFR of 22.7, positivity rate of 27.8%, mean age of 10. All the 37 cases experienced fever, rashes on the face, palms, soles of feet, and the highest proportions were those aged 0 to 5 years, with 21.6%. Male were 54.0%. Rural residents 67.6%. Family members as contacts were 49.2%, and the Isu local government area, that is the district, 16.2% are the highest reported cases. This is the epi curve. And this is epi curve, and also this is a spot map describing the distribution across the local governments. This is also the distribution. I use this table to actually describe both the age, gender, residents, and also we have the contacts. We have family member, friends. You can see family member were very high as contacts that were exposed. Then this is case distribution of suspected and confirmed across the monthly from January to November as we responded. On the discussion, 0 to 5 years, we are mostly affected, which may be attributed to the declining smallpox vaccine immunity among the age group. The rashes affected all parts of the body, with face, palm, and foot being the most affected. The occurrence of the case on contact suggests both primary zoonotic and secondary human-to-human transmission. The death recorded was on HIV-infected patient who was not on antiretroviral drugs. Then on the public, on the action, clinicians were sensitized for a high index of suspicions. Follow up with the National Reference Laboratory of NCDC to ensure an improved turnaround time of less than 48%. Training of local government area surveillance officers, and we're also taking out then isolation centers of cases and treatment were also involved. Then on the conclusion, there is currently no specific treatment for mpox and infection. It was emphasized to adopt hand hygiene, IPC treatment, IPC, and then we enhance surveillance during the response to drive active case search. The recommendations need to activate home-based care for minor cases who may wish to be isolated at home. There's need for reintroduction of vaccination against mpox, chickenpox, and smallpox, most especially among under 5 children, because more cases were recorded among this age group. My recommendation goes to the following: NCDC, MFET, PHOC of the states, and WHO were all recommended. Thank you, and thank you for listening.
Okay, thank you very much, my brother from Nigeria. And now we have Zilidzo Doreen. Do we have Zilidzo? Welcome. She's presenting on the assessment of timeliness and completeness of reporting. Serowe, Botswana.
Just touch. Can I start? Greetings to you, ladies, gentlemen, and others. I'm Zizo Doreen Lishiba from Botswana, working as a community health nurse. I'll be presenting to you on assessment of timeliness, completeness of reporting in Sorwe DHMT. Surveillance informs decisions at all levels. IDSR, which is the Integrated Disease Surveillance and Response Strategy, was adopted in 2002 in Botswana. And in this strategy, we learned that our health facilities, they are to submit a weekly report on priority diseases or notifiable diseases to the district level, and then on weekly basis. And then district also submit weekly surveillance reports to the national level on Wednesdays. However, timeliness and completeness of this was unknown, and therefore we had to summarize the timeliness, completeness, as well as to describe the commonly notifiable diseases in our district. As for objectives, I wanted to assess health facilities' timeliness, completeness of reports that are sent to the district, as well as to describe commonly reported notifiable diseases within the district, as well as to identify reasons for poor performance. When we get to method, Sorwe is a district that is in the central district of Botswana, as you can see shaded in the blue circle. It has a population of 82,808 people. It has 14 villages, 30 health facilities, in which 21 of them are government and 9 are private facilities. The study period for this exercise was week 1 to week 52 of 2022. And for timeliness, we described it as submission of weekly report every Monday before 12 noon at district level. And for national level, district submits every Wednesday before 12 noon, every Wednesday, like I was saying. And then cumulatively, timeliness was classified as good when it was 80 or more %, and fair when it was 50 to 79%, as well as poor when it was less than 50%. For completeness, we defined it as whether surveillance reports arrived at district level, either late or on time, but the fact that the report has arrived, that would be completeness. Cumulatively, completeness was classified as good if it met the national target of 80%. And we reviewed data on commonly reported diseases and presented it on trends in graphs as well as in tables. Looking into the results, our median timeliness was 68%, and the range was 0 to 87%. One will wonder, 0? Yes, because there are so many factors that can contribute to such. We'll see them as I present. And the median completeness was 80%, which ranged between 73 and 100%. Cumulatively, at the end of the year, 27% of the facilities had managed to score a good timeliness at 80%, as well as 29 facilities out of 30, which is 97%, had more than 80% completeness. As part of the results, please appreciate the graph. The black line indicates when I started being a student for FETP in Botswana on week 30. Then you can appreciate what happened after that. Okay, the green one is the facilities that reported on time, the yellow one, late reporting, and the red one, there was no reports at all. In terms of notifiable diseases, you will see that we had a total of 29,925 cases of influenza-like illnesses reported for the whole year with no deaths, and 1,796 COVID-19 cases with 9 deaths, with that case fatality rate of 0.5. Diarrhea with dehydration in children less than 5, 332 cases with 3 deaths, as well as diarrhea with blood at 126. Malaria, 5%. Other results that you would like to appreciate, this is the graph showing COVID COVID-19 influenza-like as well as diarrhea cases. We also saw results like competing priorities, lack of surveillance, focal persons, public holidays, and private facilities not prioritizing reports as a problem as well from our results. In conclusion, timeliness of reporting is suboptimal in the district, and recommendation for facilities to identify their own surveillance officers, as well as to schedule officers who will be doing the report every Monday. Public action, sensitize staff on reporting, advocated for the designation of surveillance officers, as well as advocated for platforms like WhatsApp, text, or calls for reporting so that we can be able to report on time. Thank you, sir.
Thank you very much. Is it Zidzo? Next we have David Ntumba. David Ntumba. Investigation d'un phénomène inconnu dans le village Nkonko, zone de santé de Lukafu.
Oui. Yes. Bon après-midi à tous. Nous allons vous présenter.
We are going to make a presentation on an investigation on an unknown phenomenon in the Konko village in the health region of Lukaku in Okatanga. My name is Tumba. To begin with, let me tell you that there was a rumor at the beginning of July 2022, about several deaths, between 4 and 22 death cases, many displaced populations. So that actually prompted us to investigate, to know what the phenomenon was about, and to come up with control measures. So we carried out a cross-cutting descriptive study from January to August 2022. We had to go through the medical records of the suspicious suspected patients, and we also carried out an interview of the survivors and resource persons using a form that we used for collection on Kobo Collect. We also have samples in the environment regarding the cases that we found on ground. There have been analysis with SPSS version 2022. So this is a picture of a case that we found in admission, and we were able to actually talk to the suspicious case. So what are the findings? First of all, we wish to give you the curve of trends of that phenomenon from the first week up to week 34 when we were in that area. And that curve shows you the time when we reached the area. And we can say that there was a peak on week 14 when you look at the two curves, whether it is for the cases or the deaths. So you can see that the fatality rate was quite important. Now, regarding the fatality rate by health areas, so in Konko, where we have that Konko village, they have a higher fatality rate, that is 43.3 out of 10,000. So that case we presented shows you that the phenomenon was not local alone, because it has extended to other countries, so other areas. So point 9 is, you can see almost 300 kilometers to reach that next area. Now, regarding the demographic characteristics of these cases. So the average age was 19.5, and the ratio male-women was 1 out of 4. So regarding the clinical symptoms that we listed, three symptoms were about, the headaches. Now, regarding the complications, so we had stomach aches that we found. Regarding the outcome, we have, deaths with 48%. And the exposure factor was the factor of being in contact with a case or a death within the 30 days. Now, to conclude, we can say that that investigation helped us to confirm Salmonella outbreak in Conco village. Medical care and awareness raising for the population regarding the hygiene measures and improvement of access to clean drinking water help to contribute to the reduction of the morbidity and mortality related to this disease. Thank you.
Merci beaucoup.
Thank you very much.
Next we have Abdo Ariata from Djibouti. A round of applause.
Merci pour la parole accordée, cher modérateur.
Thank you for the floor, dear moderator. Good afternoon, Chairperson. I'm Abdul Rita, and I'm a field epidemiologist, and I'm a focal point in Djibouti. I would like to present the investigation of rash cases in the National Gendarmerie. So this is actually a tropical disease that is neglected, and this has to be, reported since 2021. So this is the skin rash. So the world incidence, according to WHO, is on January 2022, the National Gendarmerie, through their focal point, notified 8 skin rash cases, and this actually, led us to carry out an investigation so that we can understand skin rash and to be able to control the outbreak in the gendarmerie, the National Gendarmerie. So that's how we started that investigation. Now, we have carried out a descriptive analysis of skin rash cases in the National Gendarmerie in November 2021 up to the 31st of January. Cases of skin rash was defined as any skin rash with pus. So a confirmed case is a case with skin lesions with prurit and confirmed by the doctor during the investigation period. And we also carried out active research, and we carried out an active research during that period of time. After a review of comments and consulting the medical records and in the community as well through an interview and observations. Our study came up with the following findings. We have a distribution of cases, and we can see that skin rash has got a predominance of prurit. We have a curve that notifies the distribution of cases in the region, and you can see in this graph that the Dilbala commune has got 30% of cases reported. In total, we have 29 skin rash cases, and mostly for males. And the median age, or the average age, was 23 years, between 2 and 46 years of age. The majority of cases, that is 72%, came from the families of the gendarmes. The investigation helped us to confirm the outbreak among the family members of the gendarmerie, and we were able to carry out awareness raising and to take care of the confirmed cases. Thank you.
Merci Abdo, and thank you very much. Now we have Gofaon Mogorosi from Botswana. Welcome. Click on it. When you're done, you close it.
Okay. Greetings, everyone. Let me get straight to it. We'll start off by introducing you to some of the terms that you'll come across in this presentation. We have what we call methomyl, which is a broad-spectrum carbamate insecticide that is normally found in liquid form. It is highly toxic with up to 10% case fatality rates, with approximately 3 million people who are exposed each year. Its symptoms include body weakness, abdominal cramps, excessive sweating, diarrhea, nausea. We also have what we call cyanide, which is a rapidly acting chemical that is normally found in low concentrations in cigarette smoke, as well as foods such as almonds, cassava, spinach, pears, bamboo shoots. This is normally used as a pesticide in electroplating metal treatment and in vehicle exhausts. It is normally found in gaseous form, in liquid form, as well as solid form. It also affects about 200 to 500 people each year, with up to 50% case fatality rates. And its symptoms include headache, dizziness, confusion. It can be anxiety, lethargy, and seizures. Let me introduce you to the background of the incidents that occurred in Dutlo village. On the 15th of November 2022, the district health management team in Kweneng received a report from Dutlo Clinic notifying them of 3 cases and a death with symptoms of diarrhea, vomiting, foaming, excessive sweating. And this prompted an investigation. An investigative team led by a frontline epidemiology trainee was conducted. This consisted as well also of a public health specialist, surveillance officer, as well as an environmental health officer. The objectives of this investigation was basically to identify the causative agent, the source of the outbreak, to describe the epidemiological characteristics of the cases, as well as develop and implement prevention and control measures. Some of the methods that we implemented: we collected water samples, biological samples for post-mortem, interviewed case patients, caregivers, as well as health workers. Active search was also done. Review of health records was also done. A case was defined as any person in Dutle village presenting with excessive sweating and dizziness and one of diarrhea or vomiting from the 13th to the 17th of November 2022. The setting was in Kwenin district, Dutle village. This village has a population of 1,464 people who are pastoral and arable farmers with limited water supply and poor access to stand pipes. Water is normally stored in 25-liter containers. These are some of the methods that we will use for our analysis. In terms of the results, we identified a total of 6 patients with 33% case fatality rates. Of these 6 patients, we had 67% being females, age ranges 35 to 61 years. 5 cases were members of the same household, that is 83% case attack rate. The 6th case was a visitor who came to the funeral from which the 5 cases emanated. The household source of water was stand pipes, and no cases were reported from the neighbor's compound. Water storage is 25-liter containers, and all the 6 cases consumed water from the same 25-liter containers. Post-mortem results for both the 2 deaths identified methomyl. And regarding our water samples, we identified cyanide, and total organic carbon was more than the normal ranges. Total coliforms, E. coli, intestinal enterococci was also more than the normal ranges. This is our EPI curve, which indicates that on the 15th and 16th, those are the days that we managed to find the cases. And then the presentation of cases by the frequency of symptoms. The most frequently reported symptoms were diarrhea, dizziness, excessive sweat, followed by vomiting and foaming. In conclusion, the investigation confirmed cyanide and methomyl poisoning in Dutle village, and no further cases were reported after the 16th of November. In recommendations, the public health unit should continue health education to the community on safe handling of pesticides, continue surveillance as well, and partner with relevant authorities to ascertain the source of the agent. Public health actions: 25-liter containers were confiscated by the police, and community sensitization on proper disposal of waste, water treatment and storage, and safe handling of pesticides, as well as treatment of cases. That is the end of my presentation. Thank you.
Yes, thank you very much. And now we have Habat Kiria Isabiri. Do we have him here? Do we have Habat? Okay, if we don't have Habat, then I would like to call on the presenters, those that have already presented, to come on the podium. I didn't see him. Do we have Antonia here? How about Alphonse? Okay, let the presenters come, please. You're welcome, quick. That's the end of all the presentations. Okay, thank you very much. We welcome you all here, the presenters. Well done for your presentations. Now we want to have questions from the floor. If you can have brief questions for each of them, if possible. Okay, go ahead.
Thank you. Wonderful presentations. I'm Gina Saman from the World Health Organization in Geneva, Switzerland. Thank you to the colleague for the last presentation about the poisoning. Can you tell us a bit about the potential the reason for why that water container may have been contaminated in the first place. Was there a police investigation, something to look at the rationale for the contamination? I have another question, if the chair would let me, to another colleague about the surveillance system evaluation. Thank you for that. The question is, rabies usually is notifiable within, or dog bites are notifiable within 24 hours to allow for rapid post-exposure prophylaxis. In this case, when you were looking at the timeliness of your surveillance system, did you look at the timeliness of reporting by case definition or by disease, notifiable disease, or did you put it all down to a weekly grouping, regardless of the disease that's notifiable? Well done to all. Back to you, Chair.
Thank you. Any other question? Okay. Yeah.
Thank you to the presenters. My question goes to Zizo, who presented on the timeliness and completeness for the Sorowe District Health team. Your definition of completeness, you mentioned that it is the reports that arrived. Would you elaborate on your completeness definition? Thank you.
Okay.
Thank you very much to the presenters. My question is for the last presenter. I just wanted to find out, you indicated that there was cyanide amongst other chemicals that were found in your lab test, as well as E. coli. How then did you get to the conclusion that this was a chemical poisoning versus maybe a multiple etiological outbreak, or rather the other causative agents? Thank you.
Is that clear? Are you taking note, please? Sorry. Okay, go ahead.
Thank you, everyone, for those fantastic, informative presentations. I have just a clarification from David. The technology didn't help. So could you, those symptoms, what did they present with, these persons? We didn't quite appreciate it. And the diagnosis, if there was one. Same thing goes for Abdo. These skin lesions, were biological specimens collected? Was there a final diagnosis? Do we know what this outbreak was about? Thank you.
Okay, can we stop there and allow them to respond before they forget? And then we'll get to these other two. Can you please respond to these questions first?
Ok, merci, bonjour à tout le monde.
Attends, monsieur. Il va répondre. Tu vas demander après.
Okay, thank you so much for the questions. I have two questions. I'll start with the one that was asking about timeliness specifically for diseases, right? Okay, here I was looking at the weekly summary surveillance reports, which looks at priority diseases. But if you look at the IDSR guideline that I was talking about, or the strategy, it has diseases classified into three. We have epidemic-prone diseases, which are the diseases that when they occur, they have a greater chance of causing an epidemic or an outbreak in a short period of time. So such diseases are reported immediately, within 24 hours, and they have specific case investigation forms. In this case, rabies will fall under that. But here I was just looking at the weekly summary surveillance report, but we have that special dispensation for such kind of diseases. Thank you. Then the second one was about the completeness. He was asking me to define the completeness in this context. When I was looking at the weekly summary surveillance report, I defined my completeness as whether the report arrived at the district level, either on time or late. Whether the submission was late, as long as the report had arrived, that is completeness, versus looking into the variables of the report. I was looking at submission of the report, not taking into consideration whether late or on time. But I know you can also look at it when you're looking at variables or the contents of the report. Thank you.
Well done.
Okay, thank you for those questions. Let me respond to the first one. That was regarding the police, whether the police were involved. So yes, the police were involved in this investigation. However, we haven't yet ascertained what could have caused, the source of this cyanide. Yes, how it got into those containers. And then the second question was regarding the chemical poisoning, if I got it right. I drew my conclusion looking at the symptoms that I presented there, so they were more relatable to chemical rather than other things that I presented. So thank you.
Bonsoir. Oui, c'était une question très pertinente que vous avez demandé. Je parle de la représentante de l'OMS.
I'm talking about to the representative of WHO from end 2021. This is part of the mandatory declaration, but during the consultation that we had, 8 within 1 week, those cases were notified by physicians, and we had an issue with confirmation. But I'm going to talk about two aspects, because we had an issue with skills, technical skills, because what was delayed was the diagnosis. So that's how we were able to see 8 cases, but we have had a lot of updates, and detection has to be done early, and the care has to be done early enough. So that's why in my definition that I said that these are actually physicians who confirmed these issues of rabies, scabies, because so the delayed diagnostics allowed us to confirm 8 cases. So after that experience, we learned a lot, and we don't have a lot of cases. We are not expecting many cases, so we just have a early care. You have the floor. Thank you. Good morning, everybody. Good afternoon, everybody. I would like to ask my question to the presentation on the unknown phenomenon. I can realize that that phenomenon presented a lethality rate of 45%, and it started from the first week up to the 34th week. So during that time, because the fatality rate is almost half, so what did delay the interventions? My question is addressed to our brother from Congo for the unknown phenomenon. I would like to know how can technically the investigation was prepared, because you are in an unknown land, and we have many deaths. How did you start it? How did you start? How did you carry out with the lab tests?
Good afternoon, everyone, and thank you to all presenters. My question goes to our colleague who present on timeliness and completeness. I would like to know if those recommendations were implemented. If yes, are we noticing an improvement or not? Thank you.
Okay, thank you very much. Merci. Vous avez la parole pour répondre.
Thank you. You have the floor to answer.
J'ai dit merci aux collègues pour des questions.
I want to thank colleagues for the questions they have asked. Regarding the first question, what was done from week 1 up to week 34, I think I would say this is one of the weaknesses of the health systems. This rumor came from the Ministry of Education, not even the Ministry of Health. We received this rumor from the Ministry of Education, and then we started to find out if this rumor was correct. And then it's from there that we started to develop the measures by asking our partners to give us some support and coming up with an investigation. So I think I could answer the two questions in that way. Thank you.
Thank you, sir, for the question. The question is on recommendations, whether they have been implemented, whether there is any improvement. Thank you so much for that. If you recall the recommendations, I was talking about advocating for surveillance officers for our facilities. I was talking about creating some WhatsApp group or any means of trying to report as early as we could. For starters, we have created a WhatsApp group, and we have also asked facilities to report on Sundays because our week ends on a Saturday. And Sundays, they can start sending reports via WhatsApp. And things have much improved. From the late reporting that we've been seeing, it's much better now if you look at the graph for 2023. Surveillance officers for facilities, we are still trying to get people that can look at that. Because if you look at it, people are multitask in our facilities. And to get somebody to look at a certain program is still a challenge. But we are trying such that at least people can be scheduled either on a monthly basis or on a weekly basis to look into issues of reporting. Thank you, sir.
Okay, thank you very much. I know my Nigerian colleague, there was no question for him, but I have a question for you. I just noticed that in your results, you mentioned the mean age of your respondents as 10. So that's not very specific, whether it's in months or it's in years. I think that needs to be clarified. And in your recommendations also, you were only mentioning what should be done, but it wasn't very clear as to who should do that, so that somebody can be assigned to take up that responsibility.
Okay, thank you so much for your question, sir. It's the EAs, actually. That's an oversight. The recommendations, like where I mentioned about the need to isolate at home, yes, is government, because government took responsibility with partner. We actually had a good support from WHO, helping us to ensure that these cases, especially the severe ones, were isolated. And I mean, in the health facility, then the minor ones, because of stigmatization, most of them prefer to stay at home. So that's why the preference of home isolation was there. So it's actually the government and partner, because we are using Public Health Emergency Operations Center to implement all our activities. So we agree, not something only government. We sit at the EOC, take actions, get partners involved, and take the lead. That is actually the answer to that is the government, because government is the owner of the program, even though the partner supports. Thank you.
Okay, thank you very much. You may take your seats. And colleagues, friends, listeners, I think we have come to the end of this presentation for today, although we missed 2 people, but this is what we have. So. Okay, thank you very much. A round of applause for them. you very much. I'm taking leave of you. Welcome. Hussein.
I have one, the first presenter.
Some guys are not sending their representative. Hi.
Thank you.
Okay, thanks everybody. Hi everybody. Okay, we started another session. The last session, please take place. Yeah. Okay, I'm Dr. Hussein Darar. I'm English and French speaker. I would like just to what is Sufu? The evaluators. Okay, first, John. Okay, best. Okay, I would like just to show the presentators. We have just we have missed 3 presentations here. I would like just to show Shedura. Where is Shedura? Shedura. Okay, good. You have okay, we have your presentation. Ziema. Wonderful. Uyoyesa? Okay, please, Uyoyesa, can you just send it your presentation for the IT man? Because we haven't your presentation here. Please, thanks. Wonderful. Togola? Here, okay. Afolabi? 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 From Ghana? Okay, we haven't Afolabi.
Hello, you have a key.
Guys was there. Okay. The IT man was there. Afolabi? Ayalne? Ayalne? Melaku Shehai Ayalne? From Ethiopia? Okay, miss it. Kruger. Ah, okay, good. Wonderful. Alicia. Okay. Irene. Sorry, sometimes I have some problems with the names. Irene. Irene from Uganda. Irene from Uganda. Okay. Thanks. Okay, merci à tous. Nous avons, I think all of us speak English. Okay, we have just, we would like just to say thanks for AFENET or thanks for all to prepare a presentation, and we would like just to show some roles. The first roles that regarding to phone. Secondly, we would like just that you respected 10 minutes. You have 10 minutes for presentation. Okay. I would like just to invite silence on the room, please. We need to start. Hi. Hello, ladies and men, ladies and gentlemen. Cuckoo. Guys, we are here. We need to start. Okay, we would like just to invite Shidura. Okay. We are started to for presentation. We would like when you present, please take place. We would like to finish after that. We make some question. When we respond, we started to go. You have 10 minutes of presentation.
Okay, good afternoon to you all. My name is Volstan James Shedura. I graduate epidemiologist from Tanzania. I'll take you through my presentations entitled High Seroprevalence and Factors Associated with Hepatitis B viral infection, a snapshot from HIV-1-infected pregnant women populations in Twa region, Tanzania. So this is my presentation outlines. So hepatitis B virus infections is a public issue now, and it accounts for about 80% of all cases of hepatocellular carcinoma. And according to WHO, as of 2019, there were 296 million people who are chronically infected with hepatitis B infections, resulting to near 1 million deaths from decompensated liver cirrhosis and the hepatocellular carcinoma. So data in Tanzania shows that the seroprevalence of hepatitis B infection varies from 5.5 to 20% among the general population and 3.8 to 8.03 among the pregnant population. So from the literature, studies have shown that the HIV-positive mothers who are co-infected with hepatitis B are more likely to give birth to children who are infected with hepatitis B, who are more likely to fail to mount protective immunity following hepatitis B vaccination. And these mothers oftentimes have high level of viremia of hepatitis B, and their progression to chronic hepatitis C is estimated to be 5 times higher as compared to those with hepatitis B monoinfections. And they have high risk of developing to liver cirrhosis and hepatocellular carcinoma. So studies in Tanzania have shown that there is a high burdens. The burden have been reported about blood donors and general population. And this is because hepatitis B is one of the pre-transfusion tests. So, but there is a limited number of studies that have been done among the pregnant women population, and especially those who are living with HIV. So we aim to determine the seroprevalence and factors associated with HBV infection among the HIV-infected pregnant women population. And we say that these findings are essential for the Ministry of Health and other stakeholders that to use as the baseline for instituting other intervention measures. And also these findings helps to align with the global health sector strategy of viral hepatitis for reducing mortality and morbidity associated with viral hepatitis by 2030, and to help also to align to help also for our way towards the HBV eradication. So we conducted a health facility-based quantitative correlation study among the 4 selected facilities in the Mtwara region from February to April 2022. And we included all pregnant women who are HIV infected, at least 18 years old, and who consented to participate in the study. And we excluded those who have prior history of hepatitis B vaccination. We used a systematic probability sampling approach with with total participants of 220, and we allocated the sample size for each selected facilities using probability proportion to size. So regarding the data collection and laboratory procedures, written informed consent was obtained from each eligible participant, and we used a structured questionnaire to collect the data, and some of the information obtained from the CTC2 cards. Data were managed, and a sample from each participant was collected from the plain tubes, and some of the initial screening was done at each selected facilities, and some of the tests were tested at the referral laboratory using automated ELISA. So those who tested positive for hepatitis B was also screened for LT testing so as to check their liver functions. So the data were managed and entered in SATA-Vision 15.1 for analysis. The total participants were 220 with a median age of 32.7 with the interquartile range of 27 to 37.6. And majority of participants had primary level of educations and were on first-line ART regimen for HIV for at least 12 months. And most of the participants with who were infected with hepatitis B, their ALC levels were normal. And generally, the seroprevalence of HBV among these women were 10.5%, including chronic infections, that was 10%, and acute 0.5%. So we conducted also multivariable logistic regression analysis, and we found that for these women, those who are multiparous with at least 4 children and who were infected with syphilis and having at least 1,000 copies per mil for HIV viral load were independent factors associated with hepatitis B virus infection among these women. So according to WHO, the seroprevalence of 10.5 is high endemicity. And we also observed this in the different studies done in Cameroon and Ghana, which show the seroprevalence range from 9.3 to 14.9. And we saw that this find is higher compared to the study that was done in sub-Saharan Africa that was showing that there is low intermediate endemicity, ranging from low to intermediate endemicity, 0.8 to 7.8%. Looking at the factors associated, we also saw that social demographic factors had no association with HB infection, which was consistent with the study that was done in Ghana. And also we saw that B multiparous was associated with the HBV, and it was consistent with the study done in Rwanda. And this, it might be true because these women, most of them are exposed with different surgical procedures and or may have different sexual patterns, also blood transfusion, which may pose risk to hepatitis B virus infection. Also, we also saw that HIV viral load, for those who had the HIV viral load, was also associated with HB infection, and this is because a high HIV viral load may have impaired the immunity of these mothers, which pose risk for other opportunity infections, including syphilis and hepatitis B, to infect these women, and this is consistent with the study done in Rwanda, which showed that most of these women who were infected were also associated with the syphilis infection. So, as a conclusion, there is high endemicity now that is existing among the pregnant women, and especially those who are HIV infected. And this underscores the need for skin-apple screening and vaccination program. For instance, for Ministry of Health and other stakeholders. So, for instance, in the routine hepatitis B screening, and not only hepatitis B, but other opportunity infection, as we've seen, for example, syphilis. And also, we recommend for instituting for hepatitis B virus prophylaxis and HBV vaccine booster dose to neonates born of the infected mothers. We think that this could minimize the burden to a more significant level. This study had some limitations that would not include the entire serological panels for this test due to financial constraints, but again, would not include more advanced techniques such as DNA PCR, which would have helped to reveal cases of occult hepatitis. We acknowledge. Thank you for listening.
Okay, thanks a lot. Okay, your respected time is completely 8 minutes. Very good. Okay, I would like just to invite Ziema from Ghana. Thanks.
Good evening, everyone. I'm Sorongmene Mwangea, presented on enablers of age-appropriate uptake of vitamin supplementation among children aged 6 to 59 months in the Nadoli-Kaleo District, Upper West Region, Ghana, 2022. This is my presentation outline. So in brief overview, we assess age-appropriate uptake of vitamin supplementation among children 6 to 59 months, and looking at the enablers as well. So we use cross-sectional study design among mothers with this age category. In all, we had over 60% of the children having age-appropriate uptake of vitamin supplementation. So the enablers were younger children, tertiary education, and knowledge of mothers on vitamin supplementation schedules. So the intervention has been ongoing in Ghana. That's the vitamin supplementation for decades, with the aim of reducing mortality associated with diarrhea, measles, and respiratory infections. So strategies have been put in place to ensure a national coverage of 80% is achieved annually. However, there are low coverages in most districts in Ghana, including the Nadoli-Kaleo district. So with also unknown factors. Previous studies have assessed vitamin supplementation with respect to time. So we use a different approach to look at the uptake of the supplementation with respect to the age schedules of the children, and also determine the enablers. This is where the study was conducted, Nadoli-Kaleo district in 4 sub-districts, Ghana, West Africa, as shown in this map. So we use a cross-sectional study design which involved descriptive and analytical phases. Mothers with children 6 to 59 months were our participants, with a previous study of 65.4% uptake of the supplementation by Latte and Ama in 2019 in Kumasi, Ghana. We estimated the sample size of 502 to conduct the study. So we use multi-stage sampling technique to get our participants. First, we sampled sub-districts using simple random sampling by randomization. So we also did same for 5 communities in each of the sub-districts. We also sampled households using simple random sampling, and at the household level, we also used the same to sample the participants. So we extracted data. We reviewed and extracted data from the maternal and child health record books to assess the supplementation status of the children. We administered questionnaires to mothers using Kobo Collect app. The data we gathered were background information, background data, knowledge on the schedules, and supplementation-related information. So we assess knowledge by asking them of the ages of initiation, completion, interval of uptake, and the beneficiary age groups. So knowledge level was assessed knowledge level was assessed based on this variable. So a woman or a respondent was regarded as having poor knowledge if she could not respond correctly to any of the variables. Good for all the variables, and fair for intermediate. So age-appropriate uptake was determined if a child took the supplementation per the age schedules, so without defaulting. So the enablers were also the associated factors we obtained using logistic regression at 95% confidence interval with Theta 17. We presented the results in proportions and odds ratios. So we obtained ethical clearance from the University of Health and Allied Sciences Research Ethics Committee with this protocol number. So our findings show that age-appropriate uptake of the supplementation was 83.9% among children 6 to 23 months, 45.8% for those aged 24 to 59 months, and in total we had 62.4% as shown in this figure. So on our factors or the enablers, we found that children who were 6 to 11 months were about 61 times more likely to receive their supplements appropriately compared to children who were 48 to 59 months. So children who were also 12 to 23 months were 8 times more likely to receive their supplements appropriately. Additionally, we had those who were aged 24 to 35 having 3.6 times more likely to receive their supplements appropriately compared to the same age group. So on educational level, mothers with, or children with mothers who are tertiary level of education were about 3 times more likely to receive their supplementation appropriately compared to children whose mothers had no education. Those children whose mothers had good knowledge level on their supplementation schedules were about 2.4 times more likely to receive their supplementation appropriately compared to children whose mothers had poor knowledge. So we interpret the results that about 2 out of 5 children were not taking the supplementation appropriately. This means that if they were not also getting the needed vitamin A supplementation from diet, they will be prone to vitamin A deficiency and its consequences, which are morbidity and mortality. Also, uptake was less among older children. This could be because after 2 years, they mostly enroll in childhood education. And our routine vaccination also ends at 18 months, except for the vitamin A supplementation. So low level of educational mothers limits their children from taking the supplements appropriately. So this is possibly because those with lesser educational level have limited access to information compared to those with higher level of education. Aside the information they receive from health professionals, they are limited to other sources of information. We also say that good knowledge level of mothers on the schedules helps the children to take the supplements appropriately. This is because once mothers know when to take the supplements, when to end the intervals, they will be able to utilize the service for their children. So we conclude that uptake of the supplementation was suboptimal in the Nadoli-Kaleo district among children 6 to 59 months. So the enablers were being a young child, mothers with tertiary level of education, and good knowledge level of mothers on supplementation schedules. So we recommend that the Nadoli-Kaleo District Health Directorate should sensitize health professionals to continuously educate mothers on the benefit of the supplementation for their children. Also, health professionals delivering the supplementation should educate mothers or inform them about the schedule specifically, targeting the less educated. Different mediums should be used to reach out to older children who mostly go to school at 2 years. So we acknowledge the following: Ghana Field Epidemiology and Laboratory Training Program, AFENET, University of Health and Allied Sciences, UHAS, a special FED, and Benka School of Public Health, the Nadoli-Kaleo District Health Directorate. This is my reference, then contact information. Thank you very much.
Okay, merci beaucoup d'avoir respecté les 10 minutes.
Thank you for respecting the 10 minutes allocated. So I would like to know whether Muyosa, are you there? Muyosa from Ethiopia.
Factor affecting the uptake of routine second dose measles containing vaccine among young children in Oromia regional state, Ethiopia. The floor is yours. You have 10 minutes. Okay, thank you.
So, good afternoon. My name is Abiot. I'm from Ethiopia. I will be presenting on behalf of my team. This is just a collaborative work. So, our assessment is factors affecting the uptake of the routine second dose of measles containing vaccine for young children in Oromia regional state of Ethiopia. So maybe as you know, measles vaccine has been in the routine vaccination system for the last more than 60 years, but measles remains major public health problems, especially in developing countries. And in Ethiopia, the measles containing vaccine was in the routine immunization for the last 14 years. But very recently, just 3 years ago, we introduced the second dose of measles vaccine. So the reason we did this assessment was since Ethiopia introduced the second dose, there was a strong interest from different partners globally, regionally, as well as in the country. They just want to know formally the progress made in Ethiopia. And again, we did this assessment in Oromia. Oromia is very big. And when we talk about zero dose or under immunized children, Ethiopia is one of the 10 countries that contribute about 60% of under immunized children. And Oromia contributes about 50% of the under immunized children in Ethiopia. So our assessment objective was one is just to assess how MCV or measles containing vaccine are delivered in the routine immunization program. And second, we went to identify factors associated with the uptake of a second dose of measles. So we did a cross-sectional study in selected areas of Oromia region. We stratified the study areas by urban and rural. We used WHO cluster survey manual to calculate sample size. And we also adopted structured questionnaire and pre-programmed in ODK to collect data. And we performed univariate regression between explanatory variables and outcome of interest, basically MCV2 uptake, and all variables with p-value of less than 0.15 in the univariate analysis were included in the initial multivariate models. So finally, we reported adjusted odds ratio with p-value of less than 0.05. So this is just demographic information. We surveyed about 1,172 caregivers. Among them, 96% of them were women with median age group of 26. And mostly they were Christian and spoke Afan Oromo. And most of them were housewives. And when we see their educational status, 35% attended primary education, while 32% had no any formal education. And when we see the household has a median, they have 1 under 5 children, and about 94% of households access the nearest health facility in 1 to 5 kilometers. So this slide shows access to routine immunization. So about 67% of caregivers has an access to fixed immunization that is static, which is provided at the health facility level, and 32% caregivers said they have an access to both fixed and outreach vaccination services. And about 51% of them reported they have there is a routine vaccination service in their community every month, while 28% said only the vaccination service is on a weekly basis. Only 10% said that they have a vaccination service in the community every day. Again, about 83% of the caregivers travel to the vaccination area on foot. 75% of them access in 30 minutes walk. And this slide shows the caregivers' awareness about measles vaccination. About 86% of caregivers reported that they know that measles have a vaccination. Of them, about only 29% said that 2 doses were needed to complete measles vaccination. And among them, about 74% get information from healthcare providers. And this slide shows caregivers' awareness on immunization. About 67% of caregivers reported that their children completed or recommended vaccines. Of them, like 29% of them believed that 5 vaccination visits is needed, while only 13% said 6 vaccination visits are needed for the children to complete routine immunization. So this one is immunization coverage. As I'm talking only about MECV2, I will focus on the graphs on the second part. So totally the vaccination coverage is about 48%, with lower coverage in rural as compared with urban areas. And this graph shows the dropout rate in 2 age groups. The lower age group is 12 to 23, and the other one is 24 to 35. So when we are talking about dropout, especially for Penta 1 to Penta 3, it is within an acceptable range, but Penta 1 to MCV1, from MCV1 to MCV2, the dropout rate is very high. These are factors associated with uptake of MCV2 based on multivariate regression. I didn't include the univariate analysis for this presentation. This one is the final model. So caregivers who, those delivered at the health facility, were more likely to vaccinate their children with measles-containing vaccine as compared with those delivered at home. And again, caregivers, those beliefs that their children has received all recommended vaccine are more likely to vaccinate their children. Again, caregivers, those knows number of vaccination visits to complete the routine vaccination as compared with those who do not exactly know the number of vaccination visits. They are again more likely to vaccinate their children with measles vaccine. Again, caregivers, those knows exactly the number of doses required to complete the measles vaccine. They are also more likely to vaccinate their children with measles-containing vaccine. So, as conclusion and recommendation, after 2 years of implementation or 2 years of introduction of measles-containing vaccine, measles vaccine remains very low in Oromia as well as in Ethiopia. And caregivers with more awareness of measles vaccine, and it is scheduled, were more likely to vaccinate their children. So we recommend here to improve the uptake of MCV2 in the second year of life. Intensified demand creation and the social mobilization are needed in Oromia and as well as in Ethiopia. So as I said earlier, this is a collaborative work between different partners, and it was funded by Gavi and CDC Atlanta. There were many partners, including the Ministry of Health, regional health bureaus, and other partners were engaged in these activities. Thank you very much.
Thanks a lot. I would like just to show if Afolabi was there. Afolabi, you know that we have three persons missing. Ayelne, Melaku, Tesai Ayelne, Iren. Okay. Okay, we have also Iran. Good. Okay. We have three. Can we go directly? Yeah. We have three presenters who have made a presentation, and we have Togola. We just invite Usman Boua Togola. Yeah, he will be there. From Mali, to present factor associated with incomplete vaccination of children 15 to 23 months. Present in French? Okay, the presentation was in French. Please take for translate.
Okay. Bonsoir tout le monde. Good evening, everybody. We thank you for your availability. So today we have the honor to share the summary of our activities titled Factors Associated with Incomplete Vaccination of Children Aged 15 to 23 months in the Health District of Tomian in 2020. It has been able... We have had the following collaborators. So for this issue, we have adopted this outline to introduce. We can say that according to the report of the 6th health survey, 45% of children were not completely vaccinated, among which 14 did not receive any dose of vaccine. So it is remarkable to realize that the efforts of the government, that is actually the gratuity of immunization, the logistics and surveillance for, preventable diseases through vaccination. In the district of Tomian, the immunization coverage was 49% and 88% for BCG and the first dose for, measles immunization. Regarding the insecurity in the Tominian Health District and restrictions of access because of the poor health coverage, the low health coverage, and the absence of previous studies, we decided to update our knowledge through this study. The hypothesis is to know whether insecurity could explain the poor coverage, immunization coverage of the district. So we were able to come up with answers, obstacles, and the reduction of morbidity and mortality for disease preventable through vaccination. We wish to tell you that this study was carried out in one of the health districts of Mali, in an administrative region called Segu that you can see in blue. So the target was 12,000 children. So we carried out a cross-cutting survey. The sampling was 780 children between 15 and 23 months. And we have realized that through the methodology that we did a descriptive analysis regarding the qualitative data, that is the proportion and the ratio for the quantitative variables. That was an average of. Now, in the statistical analysis that we carried, we run a simple logistical regression followed by a multiple logistical regression. So the final model was run using a model, and we used medical records. Now, on the ethics, we got the confirmation of the ethics committee and the confidentiality of information, all that covered all the process of the study. We have realized that the median age was between 27 and 6 years. Children were from 19 months, with more being males. We also realized that there has been contact with the immunization services that was 1.38. So that is actually a rural population, non-schooled, married with no income, with a minimum of 3 years, 3 children. The coverage of the immunization in the second dose is 29%, and the dropout rate was 53%. We also had an interaction between insecurity and the long waiting time, with a ratio of 124. So the factors associated to the incomplete immunization after the multiple logistical regression was the lack of knowledge of the importance of the knowledge of 5 targeted diseases and mothers without any income, and long waiting time, and the lack of awareness raising. This study has got its limitations. We have realized that only 12% of the samples were in a secure region, and VPO0 was not taken into account in the completion of vaccines and in the rural context and the high number of deliveries at home. So that actually pushed us to abandon VPO0. So the systematic exclusion of children without any proof of immunization status and the lack of access to some geographical regions. So our results have helped us to confront the existing review. The immunization coverage with the second dose of is 34%. It is higher than the one of Remacol in Ghana, and that of WHO Afro in 2020. But it is compared to Feldstein et al. In Sierra Leone in 2019, that is 32%. So these findings can be explained by the fact that that was the first study. Now, the high rate of dropout here, up to 50%, that depends on the WHO Afro report in 2019 and the Feldstein report. The lack of knowledge of the importance of immunization was reported in the literature in a meta-analysis that was carried out in Ethiopia, in a study carried out in Nigeria, Australia, in Mali. But all this can be explained in our context by the lack of education of mothers and the lack of awareness raising among those population. The lack of knowledge about the 5 diseases was also reported in similar studies in Nigeria, Zambia, and Mali. That can also be explained by the fact of the lack of information. So the long waiting time was also documented in 4 studies carried out in Mali as being associated to the incomplete immunization of children. And it can also be explained by the poor organization of the immunization service, the lack of a fridge in a health unit that we saw in on the field, and the lack of income because of the transportation to the target. And we have realized that in the immunization coverage and in the report in 2019. According to a study carried out in Senegal and a study carried out in Zambia and in Togo, we also realized that the absence of income could have an impact on the immunization coverage. And home delivery also was reported with a rate of 68%, which is higher than the statistical report of 2018 and the report of 2018 regarding, EDS. That is the 6th edition of EDS. In Ethiopia, this. We also realized that in the DRC and in Tanzania, there were studies that showed that home delivery could also have an impact in the non-uptake of vitamin doses. And in other contexts, we can see that there is a lack of income for mothers and the lack of geographical access and the lack of community communication. We have seen these studies in Mali in 2018 and in the investment in the speeding up of immunization. In Adelaide and et al. In Nigeria and Monet in Quebec had also come up with that situation. Then it can be explained by the insufficiency in organization, the lack of personnel in some places. To conclude, the Tomian district is characterized with a poor, coverage of immunizations, with a high rate of dropout, around 50%, and the lack of knowledge of importance of the immunization program, and the long waiting time, and the absence of income, and home delivery, and lack of education of the population, and those were associated with the incomplete, immunization, and security was not a factor. We have recommended more investment in immunizations, but mostly in communication towards the targets. After this presentation, we want to thank the audience and all the people who have been able so that this work could be carried out, the organizers of this conference and AFENET Mali. Thank you very much.
Thanks to all. We just need to discuss. We would like just to invite the two last presenters after we discuss it. Okay? Let me invite Alicia Krugers from Mpumalanga province, presenting investigation of increasing congenital syphilis cases at these districts. The floor is yours. You have 10 minutes.
Good afternoon, colleagues. Thank you. I'm Alicia. I'm from South Africa. I'll be presenting an investigation of increased congenital syphilis cases at a district hospital in Mpumalanga province from June 2022 to 2023. This will be the presentation outline. These are some of the abbreviations that will be covered in the presentation. Congenital syphilis is a severe, life-threatening disease that we find in infants when pregnant women with syphilis are not treated or when they are inappropriately treated. Over the last few years, congenital syphilis cases has increased, and then according to literature study that it was found that globally more than 300,000 fetal and neonatal deaths are accounted to congenital syphilis, with 61% of these deaths from the African region. The Centers of Communicable Disease also reported that the United States reported more than 2,000 congenital syphilis cases in 2021, which was the highest since 1994. In South Africa, we also reported 794 clinical notifications for congenital syphilis was received by the National Institute of Communicable Diseases. This was presented in their quarterly report for July 2017 to 31 December 2020. This also indicated a steady increase in congenital syphilis cases for South Africa. In South Africa, congenital syphilis is a category 2 notifiable medical condition, which means it should be notified within 7 days, either through the paper-based or the electronic surveillance system. The only recommended treatment for maternal syphilis is benzathine penicillin, and for congenital syphilis, it's benzathine benzyl penicillin. The objectives of this study was to describe the characteristics of congenital as well as maternal syphilis cases, and to describe the trends of congenital syphilis, also to identify the possible cause of the increase in congenital syphilis cases, and to make recommendations to prevent these cases. A retrospective descriptive study was conducted in Mpumalanga province in South Africa. Mpumalanga is highlighted there in green. The study was conducted in Lekwa, which is a sub-district of the Garsebande district. Garsebande district is highlighted there. It's one of 3 districts in the Mpumalanga province. Lekwa is a sub-district. As I said, it's got 1 district level 1 hospital, which means there's limited specialist services available at this hospital. The hospital also serves 8 primary health care facilities. The study population that we included in this study was all the confirmed congenital syphilis cases at the hospital, and the case definition that we used for a confirmed congenital syphilis case was any neonate under 28 days with a positive rapid plasma reagent at the district hospital in Mpumalanga province from June 2022 to 2023. Data sources included the maternal records as well as the neonatal records, notification forms that were completed, and we also obtained data from our notifiable medical condition surveillance system as well as the National Health Laboratory system. Interviews were also conducted with the pharmacist of the hospital as well as the pharmacist of one of the private pharmacies in town. Data analysis was done through Microsoft Excel to calculate the central measures of tendencies. Characteristics of the congenital syphilis cases at the hospital during the study period included the following. There were 46 cases in total for the study period. The majority of these cases were male, with 63%. Most deliveries of these cases were normal vaginal deliveries at 74%. And most congenital syphilis cases received treatment, 93.5%, and 75% were asymptomatic. The mean gestational age of the congenital syphilis cases was calculated to be 36.9 weeks, and the standard deviation 2.9. The mean birth weight, 2,745 grams, with a standard deviation of 571. And the median titer was calculated at 4, with a range from 1 to 519. For the maternal syphilis cases, we had the following characteristics. Only 52% of the maternal syphilis cases received treatment, and 56% of these cases attended antenatal care, and 66% of them tested negative for HIV. This and then another 100 doses were received in July and also another 100 in October 2022. According to literature research, there is a global shortage of benzathine penicillin since 2015. This is because there's only a few companies worldwide that manufactures the benzathine penicillin, and in South Africa this is a Section 21 medication, which means that it's no longer available on our medicine list. It needs to be bought out from other companies. So in South Africa, there's no registered companies producing benzathine penicillin. In Mpumalanga, we only have one pharmacy depot that also is responsible to supply all the health facilities in the province. In conclusion, the congenital syphilis cases has more than tripled compared to the previous year's data. The stock out of benzathine penicillin may have led to poor treatment of maternal syphilis cases, as well as the poor attendance of antenatal care. Our recommendations included that the hospital should ensure that there's adequate availability and supply of benzathine penicillin to treat our maternal syphilis cases, and for the hospital to also strengthen and promote and raise awareness about the importance of attending regular antenatal care visits, and also to test the maternal syphilis cases, or to test for maternal syphilis at delivery for those women that did not attend antenatal care. These are my references and my acknowledgements. Thank you.
Thanks. Thanks for those applause. I would like just to invite the last persons, Irene, who presenting the incidence of preeclampsia among pregnant women in Uganda.
Good evening, ladies and gentlemen. My name is Irene Chamwine Katonda, a graduate of the Uganda FETP, and I'm here to present the incidence and distribution of preeclampsia among pregnant women in Mbale Regional Referral Hospital, Uganda, on behalf of Violet Chemtai, a graduate of the FETP Intermediate in Uganda. Preeclampsia is a complication of pregnancy that is characterized by a new onset of high blood pressure, more than 140/90 milligrams of mercury, and a proteinuria of more than 300 milligrams in a 24-hour sample of urine, and at a gestational age of 20 weeks or more. The early symptoms of preeclampsia include blood vision, headache, edema of both feet and hands, among others. To note, preeclampsia affects both the fetus and the mother. However, the cause of preeclampsia is not clear. Preeclampsia affects over 13% as the incidence in sub-Saharan Africa in 2019 alone. In Uganda, the incidence of hypertensive disorders in 2014 was 13%. And in 2018, hypertensive disorders affected 11% of maternal deaths. In Bugesu region, the host of Mbale Regional Referral Hospital, where this analysis was done, preeclampsia was noted to be the second leading cause of maternal death, contributing over 17% of maternal deaths in this region. We therefore conducted a study to understand the incidence of preeclampsia among pregnant women attending the maternity in Mbale Regional Referral Hospital in 2022, and to describe the cases of preeclampsia in the same hospital in the same period. This was a descriptive analysis of maternity surveillance data from January to December 2022 among pregnant women attending the maternity in this hospital. We reviewed records including maternity in and outpatient registers and report cards of all pregnant women that attended this hospital. In this photo is Violet Chemtai, the graduate of FETP Intermediate, reviewing records to inform this study. In this study, we defined parity as the number of times a mother has given birth with a gestational age of greater than or equal to 26 weeks of pregnancy, regardless of whether the child was born alive or not. We defined a prime gravida as a woman who is pregnant for the first time, and a multipara as a woman who has had 2 or more viable pregnancies, and a grand multipara as a woman who has had 5 or more pregnancies with a gestational age greater than 26 weeks. We calculated the incidence of preeclampsia using the total number of pregnant women diagnosed with preeclampsia as our numerator and the total number of pregnant women that attended this hospital in 2022 as our denominator. We summarized this data using frequencies and percentages and presented using charts and tables. Please allow me now to present results from this analysis. Over 13,770 cases or pregnant women attended antenatal and maternity in this hospital. Of these, 328 had preeclampsia, giving us an incidence of 24 per 1,000 persons. Of these, 2 died, giving us an incidence of 6 per 1,000 persons. 78% of the mothers with preeclampsia were from lower health facilities and were referred to Mbale Regional Referral Hospital for preeclampsia. On this graph, we show the distribution of preeclampsia by age groups. On the x-axis are age groups and incidence per 1,000 on the y-axis. Age group 45 years and older had the highest incidence of 105 per 1,000 persons, followed by the 15 to 19 age group. On this graph, we show the distribution of preeclampsia by parity. On the x-axis is the parity, and on the y-axis is the incidence per 1,000. Prime gravidas had 2 times the incidence of preeclampsia compared to multiparas and grand multiparas. Multiparas women and grand multiparas women had almost similar incidence. Now, allow me to show you outcomes. 87% of mothers with preeclampsia had live births, while a little over 12% had stillbirths, both fresh and macerated. In conclusion, preeclampsia remains a burden in Mbale region, though the general incidence is lower than the estimated at national level of 13%. Prime gravidas and women older than 45 years were most affected by preeclampsia, with an incidence more than 4 times the general regional incidence. We therefore recommended that efforts to reduce preeclampsia with focus on mothers with advanced age and prime gravidas be instituted in Mbale region. Additionally, we recommended that studies to understand the high burden of preeclampsia and their related factors are conducted in this region to ensure evidence-based interventions. I would like to acknowledge the following. Thank you for listening.
Can all présentateurs, est-ce que tous les présentateurs peuvent venir ici, s'il vous plaît? Yeah, I just want to invite here. I speak in French. Yeah. Okay. Okay. Book. Until you just get to translate. Yeah. Ok, merci beaucoup. Nous avons une série de 6 présentations qui ont été effectuées. L'une partant sur la séroprévalence et les facteurs associés. Donc la première présentation, la deuxième présentation a eu accès sur la supplémentation en vitamine A. La troisième présentation sur, donc en Éthiopie, dans la zone Oromia, sur la surveillance et les doses donc, au niveau de la rougeole. La quatrième, facteur associé pour voir l'insécurité dans la région. Puis également la prévalence congénitale de la syphilis congénitale. Et le dernier point, c'est tout ce qui est en rapport avec la pré-éclampsie en Ouganda. Donc, nous allons prendre une série de 6 questions au fur et à mesure. Et chaque fois qu'il y aura des questions, donc on va permettre à tous les interlocuteurs de pouvoir poser leurs questions, mais également le temps de prendre note aux présentateurs. Merci encore pour la qualité de vos présentations. OK. Go ahead. Yeah. Yeah. Question. Est-ce qu'on peut lui donner? Yeah. Can you just get? Can I get 2 persons? Okay. One. Okay. Sorry. One. Okay. You need to ask. Okay. 1, 2, 3, 4. Okay. 5 and 6. You have your number. Please. You have 3 here and 3 here. Sorry. Number 1. Go ahead.
Okay. Thank you. Merci pour la question. Je pose ma question à la dame qui vient de Ouganda. C'était une bonne une étude, mais je suis restée à ma soif. Je n'étais pas vraiment satisfaite parce que ta discussion ne m'a pas vraiment satisfaite. J'aimerais poser ma question. Pourquoi est-ce que ce sont les primipares qui ont la prééclampsie? Qu'est-ce que toi tu peux expliquer? Qu'est-ce qui expliquerait ton résultat?
Okay.
Je crois que c'est ma deuxième question, je m'adresse au Mali.
Take note. Yeah. Go ahead.
OK. Ma deuxième question, c'est au Mali. Vous avez travaillé dans une zone qui est insécure déjà. Dans l'entrée déjà, vous avez dit que c'était une zone insécure, si j'ai bien suivi. Mais qu'est-ce qui peut encore vous pousser à aller chercher l'insécurité comme un facteur de risque, tout en sachant que la zone est une zone insécure? Voilà ma deuxième question. Ma deuxième question, merci.
OK. Numéro 2. Yes.
Thanks, Kulisa from South Africa. My question goes to our colleague from Uganda. Very interesting and at the same time very worrying, looking at the burden of preeclampsia. So I just want to check in terms of the public health actions. What public health actions have you taken to address the burden, especially to the age group above, I think it's 45 years? I just want to understand what has been done to address that particular burden. Thank you.
Good evening, everyone. I'm Patuani from South Africa, and my question is directed to Irene. Irene, beautiful presentation. So one of your recommendations was that efforts should be directed to women about 45 years old. So I just want to find out, what are those efforts? Do you have any specific efforts that are already on place? Thanks.
Okay, behind.
Yes, a very big thank you to all the presenters for the beautiful presentations. My name is Sam from Botswana. My question is directed to the presenter from South Africa. The last slide in your recommendations, one of the points raised there was for the hospitals to encourage the ANC visits. So my thinking is that, or question is that, is there any consideration perhaps for active community engagement where health promotion is given at community level to encourage people to go for early health seeking behavior instead of maybe from a hospital setting where you invite them to come? Thank you. Thank you.
Okay. Number 5? Yeah. Okay, it's the same. Yeah.
Merci. Moi, c'est Sidibé Toumani du Mali. Ma question s'adresse à celle de Rwanda. Par rapport à la tranche d'âge de 45 ans qui sont les plus touchés par rapport à l'éclampsie. Je suis un peu resté par ma faim. Si nous regardons la littérature, généralement en Afrique, c'est les femmes qui sont presque à la ménopause. Est-ce que dans la littérature, elle a vu d'autres cas comparatifs à cette tranche d'âge-là? Et je suis resté sur ma faim par rapport au cause de décès. À mon avis, ce n'est pas la prééclampsie qui serait responsable des décès, mais plutôt les complications. Je souhaiterais peut-être voir les complications c'est-à-dire les complications de cette
Pre-eclampsia. So, but you do not mention that. I thank you for giving.
Moi, c'est Youssouf.
I am Yusuf from Mali. My question complements that which my compatriot has asked, and that is to know the women of whom higher than 45 years, are they also in the pre-part? This question goes to Uganda. There's the pre-NUPA. Is it above 45 years? Is it a case of pre-NUPA? The Francophones are surprised that women are giving birth at an age which is more than 45.
Yeah, the left here. Okay, yeah. Yeah, take a seat. Okay. Yeah.
Thank you very much. I think I'm honored that my presentation has raised such questions. Sorry, I won't remember most of your names, but the first question was, what public health actions have been done to address this? So this was an analysis that was done in one region. We have over 15 regions, and one of the things that we are doing is actually doing the analysis across all regions so that we are able to inform the health sector strategic plan that is expiring next year, so that we are able to input these recommendations into the strategic plan, because this is what drives whatever is done in health. Sorry, I don't remember the first question, but I had written the answer. Oh, yes, the lady asked that the discussion was not extensive, so she did not get the causes of preeclampsia. So this was a descriptive study. So it's a descriptive study is very limited. I can only give you what I see. It's the person, place, and time at that level. So you notice that one of my recommendations was that we actually do a deeper study to understand this burden of preeclampsia. I am with you, I also want to understand. What efforts have we put in place for women over 40, over 45? What are some of these efforts that I recommend? So some of the efforts introduction of calcium, because we have learned that calcium actually can help prevent preeclampsia. Introduction of aspirin. These are not in our routine drugs that we give to women as supplements. So these are some of the things on top of the creating awareness so that the women know, because these are not things we are telling them. So you notice that in my country, actually, yes, people are giving birth at 45 and above. So these are things that they need to know, and these are some of the efforts that I hope that we are able to introduce. Women don't die from preeclampsia, but from the complications of preeclampsia. Okay, so in recording medical causes of death, the underlying cause is the cause that we take. So if preeclampsia is the cause of whatever escalates to kill the person, preeclampsia becomes the cause of death. So even with a complication resulting from preeclampsia, we are not going to take the complication as the cause of death. No, preeclampsia becomes the underlying cause of death. So hence, us taking it as the cause of death, not the complication. And the last question, I think, was, are women giving birth at 45? Yes, women are giving birth at 45 in Uganda. Thank you so much.
Yeah. Go ahead. Irene?
Thank you. Just to address my question, if the hospital, why the hospital encourage ANC? Yes, we do have community engagement, but also from the hospital side, routinely, we test all women that's childbearing age, we do pregnancy tests. And that is then where we give health education to promote them to go to the primary healthcare facilities. So it's just our role as a hospital, but we do have the community involvement and all the activities that happen at PHC level.
Yes. Anything else? Yeah. Yes.
Good evening, and thank you for the question. Why have we decided to test and yet vaccine coverage is linked to insecurity in the country? In reality, insecurity has existed. The administrative documents of the health centers and health structures talk about insecurity which has affected vaccine coverage. And the community health structures have always mentioned this. So we are trying to explore whether there are behavioral habits by the health workers, or maybe it's the community behavior which prevents people from coming to get the second dose, the second anti-measles dose between 15 and 18 months, and wondering whether the children get their complete dose. So in the light of our results, we have realized contrary causes. We've realized that most women who have not benefited from education sensitization have children who have not received the second anti-measles vaccine. So the poor knowledge of child immunization is an important cause. We also found out that the low income of women is one of the causes why their children cannot have all the doses. And those that had a low literacy rate were also more susceptible to have children who do not get the vaccine doses. So during our meeting to disseminate results to the health authorities and the community health officers, as well as the stakeholders, we realized that there are certain behaviors that even our health workers have been undertaking and that we need to do to change the situation. And some mothers, for example, who do not have enough money, cannot even take their children to the centers to have their children vaccinated, in terms of transport, even to take their children there. So that's why we're trying to intensify not only our activities and strategies but also the president of Sakako Federation, who has given these immunization cards freely, and they have put a prize for the women who will achieve full immunization of their children. So trying to transform difficulties into opportunities. Yes, we know that insecurity is a real problem, but what can we do in addition to the insecurity problem? So that's what this study was trying to find and see how we can change behavior patterns. And thank you for this question. Thank you very much. Are there any other questions? Maybe 2 or 3 more questions? So as moderator, I'm going to use this chance to ask the last question for the first presentation. I would like to know, did you carry out a viral load for the HIV positive people? Did you carry out a viral load for these HIV persons? Did you carry out a viral load for these HIV-infected persons to see whether there was resistance, primary resistance or secondary resistance? Did you also carry out genotyping to see if this, and did it work well? I would like to know if it was HIV infection, hepatitis A. So that's what I would like to know. And what treatment have you put in place to have and to address this problem adequately? And that's my first question. Now, second presenter, talking about vitamin A uptake. Did you compare the urban and rural areas as far as this uptake is concerned? And I would like to know what system of immunization is carried out in the country as far as this vitamin A supplement is concerned. And what is the national coverage? That would help us to understand this context better. Third presenter, first of all, we should take into account that Djibouti is a neighboring country. And were you able to compare other regions, or you only looked at the Oromia region? Did you look at, and for example, is there a difference between the rural and urban regions? as far as this issue is concerned? Did you also make comparisons with other regions, Tigray, Somali? Did you compare the regions? Do you have data at the national level? And then, what is the anthropological aspect of immunization? You talked about immunization because in our African context, how can a mother understand that immunization is important? Others have misconceptions. Did you look at this aspect? And then, did you look at the quality of the immunization, this movement from home to the centers? Fourth question, do you think that these home deliveries, why do these people prefer to give birth at home? And then, what is the national policy? And then South Africa, congenital syphilis. Have you compared this with other provinces? You talked about 10 provinces. And what is the prevalence of syphilis in your country? Why did you only look at these provinces? Or is it a special case in this province? And what is the anthropological aspect as far as syphilis is concerned? And in order to understand an epidemic, there's a question of multi-partners, and then unprotected sex. Unprotected sex and the first sexual unprotected sex is between young women. So how could you include that? And what is the cost of the injection for these 3 doses? Is this injection affordable for the population? Which pharmacies supply these injections? And then the last question, I would like to ask about other associated factors. I think this was a very interesting descriptive study. And if you look at national surveillance, if you compare the rural, urban areas and geographical regions, it would be good to compare the differences, especially when you look at maternal deaths, which of 11% is a high figure, but do you have more description regarding regional or rural-urban comparisons? Because this is a public health problem. And what do you hope to do beside that? So those are my questions. But this is a very, very important issue.
This is a specialist, is my area. And when I see those guys on those presentations, yeah, it's very wonderful. Okay, go ahead, please. Yeah, go ahead. We started by, yeah, sorry. We started by here.
Okay. All right. Thank you one more time for the interest in my presentation. The fact that we have a delivery rate that is high, and that delivery rate at home is high, which is statistically associated to the incomplete immunization, that is actually related to several factors. The low income of mothers, that is one of the causes. Secondly, most of the population under study are out of school, so 71%, and they don't know about the dangers related to home delivery. And the policy in my country, that is the free care for complications related to delivery, but delivery is paying, but with very low sums of money in rural areas. But culturally speaking, women have to deliver with the help of traditional birth attendants. So they come in all families. There is an old lady who is in charge of delivery for women in their community. So the first attempts are done at that area at that time. So generally, those who have a low income, who have been at school, generally they come to the health center for the delivery. When they come to the health center, the first dose is administered for against polio. So we tell them, when you come within 3 days for postnatal care, there is another immunization of the child, because the child has to receive BCG, that is the immunization against TB, before the 15 days. So from there, home delivery. So there is information on child immunization that starts to circulate within the family before even the baptism of the child. So that woman is informed. So those who deliver at home, in some areas, they say that a woman who has delivered does not come out of the house up to 40 days. So the immunization will be delayed, So there's going to be an issue with the starting. So that woman will be afraid to come back to the health center, because they say that, the healthcare professionals are going to, they are not going to be kind with her. So to avoid all those issues, all those disturbances, well, our behavior as a healthcare professional, but these are realities that are associated with home delivery. And this is actually something related to our culture. Thank you. Let me stop here and let others respond.
Okay, thank you very much for those questions. The first question was whether we compared our findings with other findings within the country and as well as within neighboring countries. So as we recently introduced MCV2, we don't have national data, or even other regions, they didn't conduct any kind of surveys on MCV2, but we do have coverage surveys for other vaccines, including the first dose of measles. And we have tried to compare with that one. And when we compared with that one, it is relatively higher, because the time we did this assessment, there were high security issues in different regions, and we excluded those areas. So it might be because of that our finding was a little bit higher comparing with previous findings like DHS. And we also try to compare with other findings like WHO. They did it kind of systematic review for MCV2. Comparing with that, it was almost similar because most of the African countries were recently introduced the MCV2. So the coverage is almost similar with that one. As I said, we don't have, especially for MCV2, we don't have national level data. The recent data we have is the one we reported from Oromia region. Regarding vaccine hesitancy, actually in Ethiopia, I can't say totally there is no vaccine hesitancy because it was demonstrated during COVID-19 vaccination. But for routine vaccination, most of the time, our mothers, caregivers, they are willing to vaccinate their children, but sometimes they have a concern on the quality of services at the health facility. And also, some of them, they do daily labor, and the time of vaccination session is not, go with their schedule. So they prefer to vaccinate their children even after work, maybe after like 5 hours after they leave from workplace. So those are the issues. So the presentation I present here was part of bigger assessment. We have qualitative assessment, we have facility assessment, healthcare awareness assessment. The one I presented was a household survey. So I think one of the qualitative will be presented in the coming days. The last issue was delivery, why mothers prefer to deliver at home. Yeah, that is a big question for our country. And most of our mothers are giving birth at home. But the government is advocating and encouraging them to deliver at the health facility. But still it is, under the government plan for that one. Maybe as I said, sometimes due to religion, culture, they might prefer women health worker at the health facilities because we do have some reports. It was not included in our study, but we have some evidences that sometimes they prefer to give birth at home. Thank you.
Thank you. Yeah.
Okay, thank you for the questions. I had 3 questions. I start with the first one. You have asked me whether in our study, we carried HIV viral load. So in our study, our main focus was hepatitis B infection. So we did not carry out the HIV viral load, but the data that you obtained in our studies, we based on the data that the result that we have already present within 6 months prior to before the study. So, and in our findings after the analysis, we found that those who have HIV viral load of above 1,000 copies per mil were significantly associated with hepatitis B virus infection. And the second question is about the genotyping of hepatitis B virus. Actually, this is one of our limitations, and we recommended that further studies that will enable to show the details on the genotyping, the subtypes of hepatitis B, but also the advanced methods that will ensure the inclusion of the cases of occult hepatitis. And another question was about whether recommendation on the treatment methods. Actually, we based on prevention more than treatment. So we based on prevention, on the diagnosis. That's why we were just want to know the burden and the factors associated. So we recommend further study that will also go direct to the treatment sides. But for our recommendation, we also think that having the hepatitis B prophylaxis for those mothers, especially in the 3rd trimester of their pregnancy, could also minimize the perinatal transmission, but also ensuring, even if the mother is affected,
the infected or the neonates if they get the hepatitis B vaccine birth dose, could also be helpful according to other studies literature that we have passed through. Thank you.
Thank you.
Okay, thank you very much for your questions. I think I got 4 questions from you, if I got you right. So in terms of the rural-urban divide, that's one of the things that I regret not doing. So I couldn't take the data on that. So going forward, it will be an important variable that I will put in my studies. So our national coverage has been below 50% mostly, and recently the World Bank estimates that it was 31% in 2022. So our coverage has been low over the years. So in terms of our immunization, so the supplements is inculcated into our expanded program on immunization. So children start taking it at 6 months up to the 59 months. So we also do it during national immunization days, but records are not taken, or it's not taken into the child welfare clinic books. They only supplement or give to the children and just tally. So that's one of the limitations that is associated with the supplementation of vitamin A in Ghana. So it will be good to put that into consideration. So also mothers' understanding on the importance of immunization. So generally they know that vaccines are good for children, despite some differences. Generally they believe vaccines do so, but the specifics are not usually known. So for our case, we asked about the importance of vitamin A supplementation, and they mostly knew about the night blindness that is able to protect children against night blindness. And I think that's even the local name that we call it. So they know generally, but the specific about all the vaccines is usually lacking. So mostly health workers have limited contact time with mothers at CWC, or that's child welfare clinics time. They want to give vaccines, they want to also give some kind of education, so they are not able to give big information to these mothers on the vaccines. So that's one of the gaps in our immunization. So I think I address all your questions as possible. Thank you very much.
Thank you. I'm going to jump right in. You asked, compared to other provinces, what's the prevalence? We are definitely not alone. Initially, when I started with the study, I did include the other districts in Mpumalanga province, and it portrayed the same picture, but for purposes of this presentation, we just minimized it. And then in the literature research that I did, I followed a study that was done in Western Cape, a province in South Africa, and I also had an increase in cases with a high morbidity and mortality rate as compared to ours. And then I did also refer to the National Institute of Communicable Disease report, which takes all the cases for South Africa. And for that quarterly report, 2017 to 2020, there was an increase in cases. So definitely it's not just for our small town, it is for the entire South Africa, all the provinces. And then anthropological aspects of congenital syphilis. So we need to follow up on these congenital syphilis cases. We treat them, and then we have to retreat and recheck them, because congenital syphilis can cause bone deformities, blindness, deafness, other neurological symptoms. So we definitely have to follow up, and if we miss any of these cases, it could be a burden on the health system and increase the costs for us, which is something that we could have prevented. In terms of multi-partners and so on, we have reached out to our private pharmacies, but they also, it's not available. So it seems like we have a challenge, which we are addressing, because we have presented to province and with the MEC. So we are addressing, and hopefully In terms of the costs to manufacture, from what I gathered in my research, it's not too expensive to manage the penicillin, and very few companies are manufacturing it now because they're no longer making money. So that is the honest truth. And definitely, I think sexual education would be one of the recommendations as well. And I didn't mention, and if I could, maybe one of the limitations also was that we didn't follow up on partners that was maybe treated because there could have been reinfection. And we also didn't include the stillbirths in the study. Thank you.
Thanks. Okay.
Thank you very much. A more description between rural and urban. Again, I'm glad that this study has tickled many minds. So this is a descriptive study that is limited. It's secondary data, so we do not have this disaggregation. So my hope is that in the further studies, we can be able to differentiate between rural and urban, and many other questions will be answered. What do you hope to do with this? My hope is to expand this and to ensure that actually preeclampsia gets noticed in the country, because we clamp it in hypertensive disorders and we stop at that. But my hope is that preeclampsia gets noticed and disaggregated out of all the hypertensive disorders, and it gets the attention that it deserves. Thank you.
Thank you. Okay, thanks a lot. Thanks for all presenters. If you have any question, yeah, the last for the last. Okay, okay, go ahead. Yeah. Okay, Izufu is the last. Okay. Okay, the microphone resists.
Thank you, the chair. For Uganda, on the preeclampsia study, you had on one of your slides that the early signs of preeclampsia are dizziness, blurred vision, the symptoms. So when you have those symptoms, that's now severe preeclampsia. And that's an indication for maternal delivery as well, because that woman can then progress and have eclampsia. So preeclampsia before the eclampsia. So if she's symptomatic, it is severe. You do mention that the incidence is the highest for those that are above the age of 45. Above 45, advanced maternal age, reduced ovarian reserve, they are likely to be having difficulty in conceiving. For your study, are these natural conceptions, or it was assisted reproduction helping them, assisting them to fall pregnant? And then for South Africa, the congenital syphilis, your mean gestational age was 36.9 weeks, and there was poor antenatal booking. However, literature does speak to South Africa has moved from a paper-based congenital syphilis system to electronic. Would you also consider the increased reporting as a contributor to also having increased number of congenital syphilis cases? And then for Ethiopia, yes, there's reduced measles-containing vaccine coverage, and that would increase the number of measles outbreaks. How does that relate to the number of measles outbreaks that you've had, given the low vaccination coverage for the measles-containing vaccine? And then for Tanzania, it would be good to know if you are doing co-testing for HIV and hepatitis B, or are you going for triple elimination or dual elimination for PMTCT? I thank you.
Okay, I think is biostatistician question, as I know. Okay, go ahead. For Ethiopia.
Yeah, thank you for that question. Yeah, actually, it is not only with MCV2. Even the first dose of measles vaccine coverage was very low in Ethiopia. Maybe the admin coverage is very high, sometimes close to 100%. But in any kind of structured survey like DHS, it is usually very low in Ethiopia. So because of this, we have multiple measles outbreak here in the Zaire. Even in the areas where reported high coverage of measles because of the denominator. Our census was conducted like 16 years ago, and now all the planning is based on the projection. So even if the admin coverage shows high, the actual coverage at the ground is very low. So because of this, we have multiple outbreaks here in the Zaire, especially in the areas where we have conflicts actually. Yeah.
Thanks. Okay. Go ahead.
Okay. Thank you for the comment. Yeah, actually, for PMTC, I think we need a joint strategy for hepatitis B and also HIV program, because we need to have early detections of these people who are infected, so that different interventional measures they can be done early, and to prevent prenatal transmission, because prenatal transmission is one of the major transmission route as compared to other.
Thank you. Yes, the electronic surveillance system is available now, but a lot of the people, specifically in the area where the study was done, still prefer the paper-based. So there's a lot of training in terms to use the electronic. So I don't think that could have led to the increase in cases, because there's only one person capturing all the paper notifications onto the electronic surveillance system. Yeah, I must admit and add also that since the start of this, the surveillance has improved. And with congenital syphilis, because I did say we use the notifiable medical condition surveillance app for the data, but we have to double check it with the lab results. Even the NMC, NICD, they do not just accept a lab notification. It has to be accompanied with a clinical notification before they accept it as a true congenital syphilis case, to avoid over reporting on this.
Thank you very much for these very interesting questions. The first one was that I mentioned the symptoms of preeclampsia. I did not commit to whether it was mild or severe. I said some of the early symptoms, because I do not think women are able to know that now I'm passing out protein in my urine. So some of the early symptoms, things someone will tell you so that you can suspect preeclampsia. So I don't think I committed to whether it was mild or severe. The second question was whether I got to know whether these were assisted pregnancies. Unfortunately, this was a descriptive study. Beyond calculating person, place, and time, we did not directly interact with these women to be able to collect such information. So my hope, again, is that in the subsequent studies that I recommend, we shall be able to answer this. Thank you.
Okay. Also, thanks for all stacks, for translators, for AFENET, for presenters. Can you applause all, please? Okay. Okay. Can you get pictures, please? Okay. Good. Okay. Good. Thanks all.